greetings to all the distinguished guests and also to all the audience. Welcome to the webinar. For this is the third Sport Emergency webinar series, which is organized by Sport Medicine's Unit, Faculty of Medicine, University of Malaya, in collaborations with Malaysian Association of Sport Medicines and also Sport and Exercise Medicines Research and Education Unit by University of Malaya. We are so honored to have our distinguished guest speaker, three of our very renowned speaker here to actually give us the talk. And also we are also welcome all the audience for joining this very interesting webinar in this wonderful Saturday. Okay, I'm Dr. Elston Chong. I'm actually the sports physician practicing in University of Malaya Medical Center. I will be the host for the today webinar. Okay, so without further ado, I would like to introduce our moderator for today's webinar, which is Dr. Goh Siu Lee. Dr. Goh is a senior sport physician, which currently practicing in University of Malaya Medical Center, and she is a very experienced sport physician, and she is also a senior lecturer for the undergrad and also master of sport medicine programs. Without further ado, please welcome Dr. Goh.
Thank you, Dr. Chong, for the kind introduction. Good morning, everyone, the speakers as well as the participants to this Saturday morning webinar, the last series of the sports emergency webinar. Without further delay, I'd like to invite Associate Prof. Dr. Sharif to give us the opening remarks for the seminar. Thank you.
Assalamualaikum and a very good morning, ladies and gentlemen. Thank you for your presence today, taking time away from your family to attend today's webinar. In today's webinar, we have three speakers who will be sharing their expertise and experience in managing or dealing with sports emergency in their various fields. We wish everyone an insightful as well as a fruitful webinar in handling sports emergency. And with that, I thank you very much, and I pass over back to Dr. Goh to continue the webinar. Thank you.
Thank you, Prof. Sharif, for the opening remark. Before I forget, actually, I just realized maybe some of you are first time joining us. So I'll just introduce Prof. Sharif. He's actually one of our lecturers too in University of Malaya. He is an organizing chairperson for our seminar. So he and Dr. Chong and a few other persons will be the key drivers of these webinars for the past three sessions. So let us now welcome our first speaker. We have actually got three speakers today who have each contributed in their special way in the field of sports medicine. So for the first one, we will have Associate Prof. Dr. Haji Muhammad Isa from UPM. He's the director of the UPM Hospital, and he has been actively involved in sports in a capacity of a classifier for the visually impaired since 2014, right? So he will be speaking to us about, he's an ophthalmologist by training, so he'll be speaking to us about eye emergencies in sports. Over to you, Prof.
Okay, thank you, Dr. Goh. Can you hear me, Dr. Goh?
Yes, we can hear you loud and clear. Thank you.
Okay. A'udzubillahi minasyaitanirrajim. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to everyone. First of all, thank you to our moderator, Dr. Goh, for your kind introduction. Congratulations to Prof. Sharif and the organizing committee and also the Sports Medicine Department, Faculty of Medicine, University Malaya, and also Malaysian Association of Sports Medicine and SAMREC for organizing this very informative seminar. This is the third series I was informed. Yeah. So myself is an ophthalmologist from UPM. Currently, I'm the director for HPUPM. My background, for those who are not familiar with HPUPM, the background is my hospital, Hospital Pengajar University Putra Malaysia. We are situated near Hospital Serdang. Yeah. So today I will share some slides with our participants some information regarding ocular injury in sports. Yeah, can I share my slide? Yeah, I've got lots of slides, but we'll just go through some the pictures. So the content of my discussion this morning is a little bit on anatomy, so that everyone is with me when I mention the terms of the structure in the eye, a little bit of background and sports injury classification, prevention, the injury mechanism, immediate management, return to play and on-site treatment, and finally the on-site evaluation and on-site treatment. Okay, so this is the diagram of the eye. I'm sure everyone is familiar with this one. Yeah. So light comes in from the front, it passes through the structures of the eye, and then it reaches the retina at the back. So the coats of the eye, we've got the outer coat, the conjunctiva, cornea, and sclera, and the middle iris, ciliary body, and the choroid. And the inner one is the retina. Okay, this is the diagram of the eyelid. Yeah, I'm not going to go into detail of the eyelid. The only thing is that this is the front one is the outer part of the skin portion of the eyelid, and the one on the right is the mucosal surface of the eyelid. Okay, and these are the bones that make up the orbital compartment. Okay, this is the edge of the end of the pyramid, where there are all the structures at the back, the nerves and the muscle that is passing through the optic canal and also attached on the wall. Okay, these are the details. These are the blood supply to the eye. Okay, the anterior chamber, the one in yellow concave is the convex one on yellow is the cornea, and then the anterior chamber, the blue one is the iris. Okay, that's the ciliary body and the angle. That's the choroid and the inner part of the retina. Okay, the uvea, it starts from the front, the iris, the ciliary body, and then choroid posteriorly. So if you look at the diagram on the right hand side, the orange inner layer is the retina, and then there's lots of blood vessels, that's the choroid, and the outer gray one is the sclera. Okay, this is the cornea. It has got 5 layers. The one on the most superficial is the epithelial cells. This is the protection for the eye. The epithelial cells regenerate very fast. Yeah, within 24 hours in a normal person, it will regenerate. However, in elderly or patient with underlying medical problem, the epithelial may take time or may have difficulty in regenerating. So the epithelial cells is the first layer of protection for the eye. There are only about 5 microorganisms that can penetrate the eye in an intact epithelial cells. All the other organisms would not be able to penetrate the eye if the epithelial cells are intact. Yeah? So that's why when one is playing sports, there's a possibility that the epithelial cells will be scraped off, and that's where the protection of the eye will be impaired, and then infection will come in. Yeah, the inner part are the structure of the cornea. I would like to take your attention to the deepest part of the cornea, the most inside. That's the endothelial cells. Yeah, so the endothelial cells do not regenerate. Once it's damaged, it will not regenerate, and it will form a permanent scar. Yeah. So these endothelial cells is very important. It maintains the clarity of the cornea. Our eye, the cornea in front of the pupil is transparent. It's because of the pump, the endothelial pump that is present in the endothelial cells. So when these endothelial cells are damaged, it will not regenerate, and then if it's the amount of damage is substantial, then the cornea will no longer be clear. It will be cloudy, and it will affect the patient's vision. Okay. So while incidents of sports-related eye injury are low, but their severity are usually quite high, as injuries to eye can result in a permanent eye damage and loss of eyesight. Yeah. So in children, 30% of the sports-related eye injury may cause a potential permanent loss of eyesight. Okay. So a blow to the eye from sporting equipment, fingers, balls can lead to injuries ranging from lid hemorrhages or laceration, cornea abrasions. I mentioned to you just now about the cornea epithelium. Yeah. Hyphema, this is a collection of blood at the in the anterior chamber, and retinal detachment, where the retina detaches from the choroid. I showed you the picture just now. Or vitreous hemorrhage, where bleeding occurs in the vitreous, and open permanent loss of eyesight. Yeah. So as I've mentioned just now, for a person to be able to see, the light has to pass through the clear cornea and has to reach the retina. So any form of abrasion, hyphema, vitreous hemorrhage will stop the light from passing through and will affect the patient's vision. Okay, so sports, there are sports injury injury in sports. The classification, there can be collision in football, rugby, hockey, contact in baseball, soccer, yeah, wrestling, non-contact, cross-country running, track, yeah, others. Yeah, so but this classification is not fixed classification. Yeah. Like for example, collision, we say that football collision occurs, but sometimes because of too engrossed in the sports, some other injury occur. Yeah, some are being kicked, others are being a lot of other things lah. Yes, for wrestling, there are instances where the wrestlers' ears are being bite. So this is the classification, but in reality, there are many other things that can occur. Okay, so the classification is just for a guide. It can be misleading. For example, hockey, it seems to be like it uses a ball and in high velocity. However, has lower incidence due to the use of protective equipment. Yeah. While golf looks as if like quite less aggressive sports, but it can cause injury, a higher risk of injury. Yeah. This is my hospital, HPUPM. We are located next to the driving range. Yeah. So the golfer are supposed to shoot the ball straight ahead. However, there are many times that the ball comes into the hospital compound. Yeah. This is the psychiatric complex, which is situated next to the driving range. and a lot of times the golf balls was shot into the complex, even in the indoor garden in the center of this complex. Yeah. And you can see this, there's a golf ball stuck onto the door, the plywood door. Yeah, so we can imagine if the golf ball hit onto an individual. Okay. So in terms of the high risk, there's low risk where there's no use of ball, park, bat, stick, and etc. And high risk when there's like baseball, hockey, football, fencing, golf, and the rest. And in very high risk where there's potential contact to the participant, and especially frequent high impact trauma to the eye with no eye protection typically worn. So research indicates the beginners are more prone to eye injury than intermediate or advanced players, as beginners are yet to learn or refine the skills. Yeah. Sports can be classified on basis of high risk, moderate risk, and low risk. Okay. In high-risk sport, it involves small, high-speed, dense projectile in close proximity to the athletes. Example are sports with small, high-velocity projectiles. Yeah, air rifle, paintball. Yeah, these are the things that the army use in the war. Yeah, but as we develop and everyone wants an experience to see how is in the battlefield. So we created new games, air rifle, paintball, and etc. Yeah. However, using a proper protective equipments, it can be not so dangerous. But at times there are people who do not use the protective gears. Yeah? Sometimes they use the goggles get foggy and they take it out, and that's when injury occurs. Okay. Sports with hard, dense projectiles, fingers at close contact, or use of bat and stick. Yeah? For example, all this badminton, baseball, basketball, cricket, fencing, and the rest. And moderate risk sports involving high-speed ball or park, the use of bats and stick, close aggressive physical contact. Example like American football, archery, soccer. Okay, the low risk are those that do not have close physical contacts among the participants, like athletic, cycling, skiing, swimming. However, injury can still occur in these sports. Yeah. So the main thing that needs to be emphasized is prevention. Yeah. Most eye injury in sports are preventable. Yeah, minimizing the severity and the incidence of eye injury in sporting environment is based on the following three principles. One is modifying rules in junior sport to limit the risk and ensure safe play. Developing coaching procedures and practices that encourage safe play, and where appropriate, wearing protective eyewear which meets the approved standards. Okay. Functionally one eye players, yeah, who have poor vision on one or both eyes should wear appropriate eye protection. Yeah, because these participants, they have got only one precious eye. So they need consultation from the ophthalmologist and optometrist before they can join into doing these games. Yeah. Myself as the classifier for each visual impaired Paralympic, this is where we will examine, but my role is more of the classification to ensure that the participants goes into the proper category. Yeah. Okay, next is contact lens. Yeah, everyone have to bear in mind that contact lenses offer no protection. Yeah, therefore players who wear contact lenses must also wear appropriate eye protection. And thirdly, obeying the rules. The importance of good sportsmanship and fair play should be emphasized. Coaches should develop clear rules for training, general conduct, and always discourage violence or dangerous techniques. Okay, wearing protective equipment. Appropriate protective eyewear is a proven measure to prevent eye injuries in sports. Wearing appropriate protective eyewear is strongly recommended, and ordinary prescription glasses do not provide adequate protection. So the basic steps in choosing protective eyewear is including using only eye protectors that are recognized or approved, having an ophthalmologist or optometrist assist the athlete in selecting and fitting the appropriate protective eyewear. The design of the eyewear, the material that the eye protection are made is very important. Okay, for example, in sports that are exposed to very high light, or strong lights, so the protective eyewear needs to be proper. For example, if they need to use tinted lenses, so the tinted lenses has to be of good quality. Even those who are not playing sports, when we are choosing our shades or our tinted glasses, it has to be of good quality. Otherwise, the shade will make the pupil dilate further. So when the pupil dilate further, that means more light will come in. So if our shades do not have the UV light protection, then we are actually, by wearing that tinted glasses that is not up to the standard, will encourage more light, more UV light to go into the eye and cause damage to the eye. So the eye protectors must shift impact from the eyes and the face to the skull without causing intracranial injury. So this is the standard. May be necessary to integrate into helmet in hockey, football, baseball, and so must be acceptable to the athlete and not change the appeal of the game and not generate unacceptability and unacceptable liability. So this is the features of the eye protection. The athlete should be comfortable to use it. And then it does not change the appeal of the game. By using that eye protection should not make the athlete less or more handicapped. So it has to be acceptable, otherwise it will not be used. Similarly, like our welders, they tend not to use the protective equipment, because it disturbs their work. So that's why we get the welders coming in with the injury to the eye due to the radiation. Okay, so this is an example of the eye protection for a basketball player. Okay, the material is made, it has to be highly impact resistance, capable of absorbing ultraviolet light, like I mentioned just now, available in prescription and non-prescription lenses, and multiple standard for particular sport. So there are athletes who need to use their own glass. They have a refractive error, so they need to use corrective lenses. So if the protection equipment do not have the lenses that can accommodate to their refraction, then they will use their own glasses on top of that protective equipment. So that will cause more damage than actually protect, because the protective equipment will press onto the prescribed glasses, and that will cause the frame to buckle or the lens to break and then injure the eye. Okay, the mechanism of injury, there are blunt trauma. This is the most common mechanism. They can cause blow-up fracture, contusion, iris injury, rupture, traumatic iritis. I'll show some pictures of what these things are. Yeah, blunt trauma. The damage depends on the size. Yeah, size of the thing that is hitting the eye, and also the hardness and the velocity of the blunt object, and the force imparted directly to the eye. Yeah? So objects smaller than the orbital opening causes a rapid anterior-posterior compression and dilatation of the middle globe, transferring the force to the internal structure. Whereas the objects larger than the orbital opening will exert the force on the floor of the orbit or the medial wall and cause fracture of the thin bones. Okay, so this is the illustration to show about the mechanism of the blunt injury. Yeah? So in this picture, there's a fist hitting the eye. Yeah, so if you can see, that's the globe in the center. On top, there is the upper part of the orbital wall, and the lower one is the lower the floor of the orbital wall. Yeah? So on the diagram on the left, when the fist hit the eye, the structure will be compressed to the posterior part, inner part of the orbit. Since the orbit is a confined structure, so it will find way to go to transmit the force. So the most part of the orbit that it will be affected will be the medial wall of the orbit, which is the thinnest, and the next one is the floor, as seen in the right diagram. The orbital content has gone down into the maxillary sinus inferiorly. Okay, so this is the picture of a gentleman that has that sustained an injury onto his right eye. Yeah, we can see he is trying to see to his right. Yeah, but his right eye is not moving, is looking straight ahead. Because if you can see the CT scan, the scan inferiorly, the medial wall is fractured, and there is an entrapment of the muscle that stops the right eye from looking to the right. And also this individual is trying to look up, but on his left eye is not moving, is still looking straight in front because the floor of the left orbit is fractured, and the orbital content has prolapsed to the sinus inferiorly, and has trapped the muscle that stops the eye from being elevated up. So this is some pictures of the globe trauma. Yeah, there's close injury. There's the intact cornea and the sclera, but there is intraocular damage. Whereas open injury is associated with full thickness wound of the cornea or the sclera or both. Yeah, and for open injury, you can divide into rupture, where the full thickness of the wound is by blunt trauma. Next is laceration, where the full thickness wound is by a sharp object. And the other one is penetration. Yeah? Penetration is caused by a single laceration with a sharp object. And perforation, there's two laceration, one entry and one exit wound. Okay, so this is a photograph of the cornea with abrasion. Yeah, the fluorescent lighted area, the area where the epithelium is scraped off. Yeah, the surface of the cornea where the epithelium is still intact is stains. It does not fluoresce. you can see the is under the cobalt blue light. Yeah. So when stain is put onto the nude epithelium, then it will fluoresce, whereas the normal one will not fluoresce. Okay, there's a foreign body on the cornea inferior to the pupil. Okay, there is a pupillary tear. Yeah, the pupil margin is teared inferiorly. Yeah, so in this case, the blunt trauma, like just now, as the fist hit the eyeball, the structure are pushed backward. So once the aqueous in the anterior chamber between the cornea and the pupil will all try to rush through the pupil, and that's where it will tear the pupil margin. Okay. Then this is hyphema. Yeah, the right ray of light is the reflection of the cornea, and at the back you can see the pupil and the iris. So this is blood in the anterior chamber between the cornea and the iris. So this also can be due to a blunt trauma. Okay, then this one, the lens is now in the anterior chamber. So again, blunt trauma, it pushes the structure of the eyeball in posteriorly, and as the aqueous rushes through the pupil, it will stretch the pupil open big. Yeah, if the force is enough, it will be bigger than the lens, and because of the different the different speeds they are moving, so the pupil will go past the lens, and when the force is removed, the lens is trapped in the anterior chamber. Okay. This is when the iris is being derooted from its insertion. Yeah, this is also due to this is also evidence that we can see after a blunt trauma. Okay, this is also some evidence in a blunt trauma where you can see pigments onto the lens. That's the shape of the pupil when all the structure are being pushed to the back because of the force of the trauma. Then the pupil margin is imprinted onto the lens. So these are all evidence that we can get in trauma even long after the trauma. Okay, posteriorly, this is commotion-retinae. Yeah, the whitish part is the abnormal retina. The one on the right is the normal retina that we see. So the normal retina is transparent. You can see the vessels on top of it, and then the red glow is from the choroid. Yeah, from my diagram just now, I showed you where the choroid is. So the red glow is a normal retina getting the glow from the choroid, but on the left-hand side, the retina is no longer transparent. Because of the trauma, it is swollen, and then it becomes opacified. That's why the glow of the choroid is not seen. And this is the choroidal tear. Yeah. So because of the blunt trauma, everything is all pushed backward, and then at the back it stretches. So why it is in a curve shape is because of the shape of the eyeball is a sphere. So when the force comes from the front, it will break in a curved manner. Okay, this is a blunt trauma with minor external. The one on the left, minor external trauma in the presence of severe ocular injury. Yeah? So from the front, from anteriorly, you don't see much except for that laceration inferiorly. But on the right hand side, there are bleeding in front of the retina. That's inferior to the orbit. I saw some message at the chat. Is there anything? Okay, that's the question. Okay. Dr. Go?
Yes, Prof.
I got until 10:45, right?
Yes, 45 minutes.
Okay, sorry, I'm just checking my time. Okay.
Sure, you're in good time, yes.
Okay. This is the blunt trauma causes the rupture on the left side, ruptured the globe, and this one is the right. On the right side there will be laceration on the eyelid. Okay, blunt trauma, extensive conjunctival hemorrhage, and hyphema on the right. Yeah, commercial retina I've shown you just now, choroidal rupture. Just now, I've shown you a one choroidal rupture with lots of bleeding. This is the later on. Yeah, later on, as the bleeding all subside, then you can see the white line. That is the choroidal rupture area. And then the late complication, there will be new vessels. Yeah? The dark area surrounding rupture can affect the vision. There will be new vessel coming out from the choroid. It comes up into the this subretinal space. Okay, penetrating injury. This is all common sense. Yeah, like projectile, eyeglass break from the improper eyewear. Just now I mentioned. Yeah, fishing hook. Canaliculi laceration usually occur because of trauma from a fellow player's finger in the area of the medial canthus. Yeah, so the fingers with fingernails are long. Yeah, when it caught the eyelid and then being pulled, it can avulse the eyelid from its insertion. Fishing hook. Do I have a picture? I think I've got a picture. Yeah. You can see on the left hand side there is a fishing hook that is trapped in the anterior chamber of the eye. Yeah, so the hook has penetrated the cornea and is now the tip and part of it is in the anterior chamber in front of the pupil, and part of the hook is left outside. Yeah. So how does this normally occur? Yeah. We may think it will occur to the one that is casting the fishing line. Yeah, but actually this one will occur to the spectator. Yeah, normally spectator at the back of the one that is fishing. Yeah, so as the one that is fishing is casting the fishing line, yeah, as it throws to the back and pull to the front, that's when, if there's any spectator at the back, that is when it will occur. It will hook onto the eye of the spectator. Yeah. So in this case, do not try to remove. Yeah, you will cause more damage. What we do is that you just tape it, or if you don't have tape, just leave it as it is and shield the person's eye. Yeah? Do not put a bandage or a gauze. Just shield it. If you don't have anything, just leave it as is. Yeah, because otherwise it can cause more injury. Like I said just now, the cornea has got 5 layers. The epithelial defect that we see, the fluorescent, is on the epithelium. This one, we are worried about the endothelium. Yeah. Now the part of the hook is already inside the eye. If we were to meddle and then the hook will scrape onto the endothelium, then it will damage the endothelium. And as I mentioned, endothelium will not regenerate, then the cornea will no longer be clear. It will be opacified. And in this case, unfortunately, if it's in the visual axis, if the endothelium is damaged there, the central vision will be affected. Okay, this is quite common now in Malaysia. Yeah, archery. Yeah, it can occur not only to the person that that is in front where the what do you call that, the spear goes, it can also happen to the one that is handling the spear. Yeah, because the spear is quite long, sometimes we forgot that the edge is near our eyes. Yeah, so this one they have to be careful. And my children also play this archery at home. I will always tell them, do not shoot the arrow if there's anyone in the front of or near the target board. Okay, this is this happened in not in Malaysia. Yeah, the arrow hit this unfortunate boy, and it passes through his skull until the back of his skull. Yeah. So in case like this, please do not try to remove the arrow. This boy is being brought to the hospital with the arrow stuck to his eye and skull. Yeah, do not try to take it out because it will cause more damage. Okay, so this one, the arrow went through the 11-year-old boy. It was until the back of the skull. Yeah, a 16-inch was embedded onto his skull. Yeah, so this is the X-ray showing that the arrow it hit onto the back of his skull. Okay. Radiation injuries, this is not an acute one. It occurs over time. It can also occur in a normal individual not involved with sports. That's the pterygium and the pingula. Yeah. So when we are on site, if there's any injury to the eye, look at the tenderness, swelling, bleeding, bruising, double or blurred vision. Yeah, there are different types of injuries present with the specific symptoms. Okay, cuts or scrapes to the eyelids caused by fingernails and fingers usually result in redness and pain, which should clear within few days without serious long-term effect. Yeah, but however, like I said, if the epithelium is scraped in an individual who have got diabetes, who have got poor healing of the wound, it will cause the delay in the healing, or the healing will be of an abnormal epithelium that will tend to recur. The epithelial defect tend to recur. Yeah, blunt trauma caused by blows from fast-moving projectile, they can cause bleeding internally or within the eye itself. Yeah, externally or internally. And also blunt trauma can also cause broken bones around the eye. Yeah, penetrating injuries and foreign body penetrates into eye. It will likely occur when sports participants are wearing ordinary spectacle lenses. They can shatter onto the impact. Okay, immediate management, do not examine or touch the eye. Do not forcibly remove any foreign object from the eye. Gentle flushing with clean general saline to remove dirt or grit is reasonable. Do not administer any creams or eye drop before medical assessment. Yeah. Pat the eye in certain cases, but in cases like I've said just now, do not pat or bandage the eye, just put on the eye shield. Yeah, pressure to the injured site should be kept to the minimum unless there's a profuse bleeding, and keep the player comfortable. Consult a medical practitioner or eye specialist to attend the emergency department at the nearest major hospital. These are the cases that would need an immediate referral: sudden decrease in vision, loss of visual field, pain on the movement of the eye, photophobia, diplopia, proptosis, light flashes, irregular shaped pupil, suspected globe perforation, foreign body sensation, red and inflamed eye, hyphema, halos around light, laceration of the lid margin, subconjunctival hemorrhagia. Rehabilitation and return to play. Athletes with serious eye injuries should be examined by an ophthalmologist and return to play only if the doctor says it's safe. The injured eye should feel comfortable and have adequate vision. For a less serious injury, the team sports medicine professional can usually decide if the athlete can return to play based on the type of injury and how the athlete feels. Yeah, so athletes should never use topical anesthetic so that they can keep playing, because this will anesthetize the surface of the eye and will cause more injury because they won't be able to feel the pain. Okay, in the patient with significant ocular injury, a full examination and clearance by ophthalmologist is required. The eye should feel comfortable and adequate return of vision. During the game, immediate return to play depends on the athlete's symptoms and the nature of the injury as determined by the team physician. Athletes should never be allowed to use topical anesthetic to prolong the play. Functionally one eye. Okay, this one will need a proper examination and the protective lens required. Okay, sometimes we can do also pre-participation examination. If patient, the athletes high likely to develop this problem. Yeah, so we take a ocular history, see if there's any problem with the eyes with glasses, ocular history, family history of retinal detachment and the rest. Yeah, and a complete eye examination. Okay, the acuity, the visual field, the any other unequal pupils, fundoscopic examination. Yeah, so that if there's any injury that occurs, we know what's the baseline of the athletes. Yeah, so for example, an athlete may have abnormal pupil, one is big, unequal pupil, which is normal, which is there already before the game. So we won't panic and try then, because we have the baseline for finding of the patient. Okay, and then the bag, the team physician bag. These are just guide. Yeah, not necessary to have all. Yeah. Emergency telephone numbers we have all in our handphones. Yeah, near reading card, useful to assess the vision, but normally on site we don't do vision checking. We just do grossly to see the athlete can see clearly or it's blurred. The ocular pen light is handful with the cobalt blue. Yeah, topical anesthetic. This is for ophthalmologists, if it's got ophthalmologists on site. Yeah, dilating agents also not necessary if it's just a general physician. This only used by ophthalmologists. Fluorescein strips. I don't normally encourage fluorescein strip, but in where I practice, it is being used in the emergency department. Actually, when you just shine, you will be able to see the area of denuded epithelium. We don't need the fluorescein staining to check it, because once it's stained, then a subsequent examination of the patient will be affected. So, but some ophthalmologists do it in the emergency department. Yeah, cotton tip applicators, yeah, eye pads, eye shield. Yeah, tape, sterile ocular irrigant. Yeah, for when if there's any debris onto the wood. Yeah, and then topical antibiotics, contact lens, case, and solution. Yeah, sometimes this the athlete uses contact lens when they are playing on top of their protective equipment. So at times you need to keep and take the lenses out. Then the other is all the normal emergency equipment. Yeah. So on-site evaluation history, mechanism of injury, object, force, direction of impact. The pupil examination, look for anisocoria, the light reflex, and the consensual reflex. Pen light examination of the anterior chamber, look for foreign body, hyphema, abrasion, laceration. This is on the right is showing the staining of the eyeball, yeah, which I normally don't use it in the emergency department unless it's in the ophthalmology examination suite. Okay, both eyes should have full motility in all position. External examination, look for periorbital ecchymosis, edema, and we palpate the orbital rim to look for the step of deformity that will tell us a clue that there is some orbital rim fracture, and also plus and minus the orbital wall fracture. Yeah, pain when opening the mouth will occur with fracture of the lateral wall of the orbit, and then paresthesia where there's impingement of the infraorbital nerve. Okay, and then fundoscopic examination, normally we don't do on site. Evaluate the red reflex to see the bleeding, internal bleeding, the vitreous hemorrhage. Yeah. For cornea abrasion, superficial cornea, foreign body, concealed foreign body, eyelid restoration, hyphema, shield the eye and refer immediately. Don't try to remove the foreign body or pad or do any manipulation to the eye. Yeah, blunt trauma, look for facial fracture, globe injuries. If the athlete is comfortable, not much of pain, examination looks fairly normal, then we just give rest, analgesic, and cold compression to control further edema and discomfort. And management, complete systemic assessment, apply eye shield, do not patch the eye in the area in case of there's ocular laceration, and immediate referral. Okay. This is the photograph of the eye where there's a laceration wound, so there is no anterior chamber anymore. Yeah, so the green light ray is the cornea, and the pupil and the iris is in contact with the cornea. So the anterior chamber has collapsed because of the penetration wound that has released the aqueous humor out. Okay. This is also a penetrating injury, but the anterior chamber, not all the aqueous has come out because it has already been plugged by the pupil. Yeah. So in cases like this, don't try to maneuver the pupil in and push it using the cotton buds or needle stick or whatever. Just shield the eye, send the patient to the emergency department. Yeah. So because the aqueous is still there, some are still trapped there because of the iris that is plugging the wound. Okay. And this is the ruptured eyeball. Yeah, this is when already in the operation theater we have already opened up the eyelid. Yeah, on site it will not look like this. It can just look like a raccoon eye or a hematoma of the eyelids. Yeah, so don't try to force open to see the eye and to check what's happened. Yeah, so because if underneath the swollen eyelid is something like this, when we force open the eyelid, the orbital content will come out. Yeah, what you can see here, the darkish material at the lower part of the photograph with blood vessels on top of it. That is the retina and the uvea that has already prolapsed out of the globe from the wound. Yeah. Okay. That's all. It's already 10:40. That's all that my presentation. More of a discussion. Yeah. I'm just sharing with you the information. Yeah. So thank you very much for your kind attention. And back to you, Dr. Goh.
Okay, thank you, Prof, for a very informative talk. I'm sure all the participants have enjoyed it a lot. I especially enjoy your sharing about the golf balls in your hospital. Yeah.
I'm still praying hard because we have not put the net yet. The safety net is not yet there. So
yeah, okay. Until then, I was thinking maybe you should keep the next speaker's handphone number in your speed dial. You know, the next speaker's going to talk about concussion, right? So it might happen to anyone in your compound.
please don't.
Yeah. So just a thought. I'll introduce the next speaker to you later. If you haven't known him yet. But for now, I think we have got questions. A few in the chat, in the question and answer section. So the first one that has been compiled by Dr. Elston is the question is about what are the microbes that can penetrate the eye endothelial layer of the cornea? Can chemical also cause eye injury as for example, the chemical used for cleaning equipment? That's the first question. Yeah.
Yeah. The five organisms that can penetrate the eye without intact cornea. That's a master's exam question.
I see.
So I leave up to the audience to go back and find out the answer.
Okay.
Okay. And then the other one is what? The chemicals, is it?
Yeah, can chemical cause eye injury? I'm not sure why it's a special mention about cleaning chemicals used for cleaning equipment. Is it different?
Yeah. Actually, yes. There is a classification under the ocular injury, but I didn't include in here because not most of the time it's not the sports injury, but it's more of the occupational hazard. Yeah. So most of the thing that occurs in developing country are cement. Yeah, there are lots of construction going on. Then cement goes into the eye. The rest, there are all other chemicals. All can cause injury to the eye. Depending on to the concentration of the solution, the type of the solution, whether it's an acid or an alkaline, it can cause damage. The damage is that it kills the cells that the limbic cells at the periphery of the cornea. These limbic cells are the one that produce the epithelium. So when there's chemical injury, the limbic cells depend on how big the damage is. Then it can cause the epithelium to be affected and the denuded epithelium. And in severe cases, it can cause the dense cornea. I've got a picture of that, but I didn't put it up because I thought it's not really sports related. Yeah, Dr. Goh.
Okay, thank you. I hope that answers is it Dr. Ahmad's question. If you think that it's not appropriately answered or not sufficient, maybe you can come up live and ask again or in the chat box. So at the meantime, we'll go to the next question. It's about what are the signs and symptoms to look for, especially on site when you are thinking of endothelial injury of the cornea, because as you said, this is a non-regenerative part of the eye. It's quite important to pick this up early, isn't it?
Yeah, but that one we won't be able to tell immediately, because there are epithelial cells that will be pumping the cornea clear, so it will be clear for a while until then the functioning one is inadequate. Then the cornea will start to be opacified. But in penetrating injury, like the fishing hook I showed just now, if we try to meddle with the fishing hook, then we can see on the spot there will be opacity of the cornea area. So, but it's a little bit microscopic. Sometimes you can't see with the naked eye, but it's very important not to meddle with any things that is embedded onto the eye.
Okay, so the message, if I'm correct, is that seemingly what do you call that? Small injury may be actually manifest at a later stage where you need kind of continuous assessment to pick up some sinister injury. Is that right?
Yeah. So the important message that I want to send is that do not meddle with the anything that is embedded onto the eye, because it can cause damage later on, not immediately seen.
Okay. So the third one would be how do you manage a blowout eye injury on the field?
The blowout is that we don't that sometimes the lid is very swollen, so don't try to force it open. Just shield it or lightly pat the eye if there's no wound. Lightly pat the eye and then send the patient for further consultation.
Do you give any medication for pain or anything like that, or it's just pack and
Yeah,
send?
those are standard symptomatic treatment like pain and reassurance of the patient and not make them more panic.
Would you transfer them like sitting, or can they just walk and run? Is there like a precaution to be taken?
Normally when
Intracranial pressure, for example, would that be?
normally when injury occur, normally they will all be ferried onto the stretcher, right? So that's why I didn't mention about that one. But the most important is that not try to press open the eye, so that you will not create more unnecessary damage to the ocular structure.
Okay. Okay, thank you. So we're going on to the fourth one from Afsal. Unlike amateur boxing, headgear and any type of face protection are usually not allowed in professional mixed martial arts, I think, where direct blow to the eyes are common. What are the preventive measures that can be taken prior to the match to prevent this eyes injury?
Okay, I'm not very athletic, so but from my knowledge, for those martial art, they have got specific instruction. Yeah, there's a certain areas that should not be hit, and it has to be avoided. If the opponent hit that area, is disqualified, something like that. Is that true, Dr. Go?
Yeah, I myself am not really into mixed martial arts. I know some people in the group. Maybe we can get Dr. Nick or Elson.
My children go for taekwondo, but I was told that there's certain area you don't hit above the torso. You only hit at the torso and the limbs for martial art, for competition martial art. If that's so,
because taekwondo is relatively gentle compared to mixed MMA.
Mixed martial art, the eye definitely is a no-no area, and also, but of course, mixed martial art compared to other those boxing and also other combat sport is actually more dangerous because of they are wearing less protections, especially the headgear. But certain area, of course, the eye is direct hit to the eye is actually are not allowed.
There's also some martial art that uses the sticks. Yeah, so but they have got that rules and regulation. That's why it's important for the athletes to be real sportsmen and not try to injure the opponent.
Yeah.
Okay, so basically it's just through rules, right, to prevent injury to the eye in MMA.
Yeah. Rules and proper usage of protective gears will avoid injury. So that's why it's very important to emphasize to the athletes.
Okay, so next comes the, okay, I think you have sort of covered this, but just to maybe emphasize, in your experience, what are the most commonly missed type of referrals that were supposed to be done early but not done? And is it because they thought it seems to be benign at first, and then it just didn't occur that it will cause more problem at a later stage? Is there any? message that you'd like to?
Mainly they are all those occult one, which is not seen physically. Yeah, so any form of abnormality that the patient, the athlete complain, we need to review. Yeah, for example, like I showed just now, there's only a small laceration at the lower lid, not much of swelling, but at the back in the retina, they are bleeding. They are bleeding in the retina. So when there's bleeding, like a picture I showed just now, the patient will definitely have some visual complaint. So it should be managed, referred to the ophthalmologist.
Okay, because as far as I know, some like just a direct impact, which is kind of benign, will still give you some visual disturbance for a short duration. So what kind of visual disturbance are you talking about that will suggest important condition to be managed by ophthalmologist?
Like I said, in the history, we see to the situation. How is the injury occur? What sort of injury ball, the density of the ball that is involved, and also the velocity and the situation is occurred. Then even though patient has just got just slight blurring of vision, we do refer. But normally the athlete themselves or the patient themselves will not be happy when there's some form of disturbance in the vision, which tends to persist and do not go off within that few minutes. Then they would want themselves to be examined, I think. Yeah.
Okay, thank you, Prof. Yeah, the next question is about contact lens in sports. What are the common problems you see, and how do you manage these problems?
Basically, contact lens is not to be used in sports. That's why we have the goggles with power, other protective gears with power, because the contact lens is on the surface of the eyeball. So any form of trauma will cause abrasion to the eyeball, and those who are using the hard contact lenses, it will also give more damage. So contact lenses in our community has been taken very lightly. Yeah, we have patients who have got no refractive error but use contact lenses because of they wanted the blue iris, green iris, or to match with their clothes, the red contact lenses to match with their clothes. Yeah,
Their hair maybe.
So I've got patient coming in with cornea ulcer because of the cosmetic contact lens. They don't have refractive error. That's number one. Number two, individuals who are using contact lenses because they have refractive error do not have a spare spectacles. So everyone who uses a contact lens have to have spectacles. The moment they have a slight redness of the eye, the contact lenses have to be off. They have to use glasses, no matter how horrible they look using glasses. And then in sports, yeah, so there are a lot of people who sleeps with the contact lenses also. So by the time the morning, then the cornea is suffocated. The oxygen supply is inadequate. So definitely sports, we don't encourage contact lens to be used because of the possibility of the trauma.
Okay, Prof. So very quickly, the last three questions are here because we've got only 5 more minutes. So the last three is if a cornea abrasion is seen on fluorescein staining, would the patient be seen by ophthalmology team immediately, or can they defer the referral to the next day? or what should we do in the ED setting?
Yeah.
How do you treat it?
So yeah, normally, if I'm on call, I would always I do not encourage fluorescent staining in the ED. Because like I say, by using a pen torch, you'll be able to see the defect onto the cornea. So refer to the ophthalmology team, and they will do all the necessary tests before eventually staining to see the extent or to take the intraocular pressure. Any defect, normally we will, for the ED team, just refer to the ophthalmology department, because this epithelial defect, like I said, the protection of the eyeball is no longer there. The first line protection is no longer there. So we will assess, we will start topical antibiotics and some pad. I don't pad, because if you don't pad also, the epithelium will still grow back. Yeah, and if you pad, normally I don't like padding, because sometimes when you pad, there's infection ongoing and it get worse because of the dampness of the padding. Yeah.
Okay, so you
yeah.
refer immediately, right?
Yes.
Okay, so the next one, in case of arrow stuck in the skull, how would it be removed? Because I guess it's, I don't know, do you remove it or the surgeon?
This is a multidisciplinary effort. So we will assess, and who comes in. If it's already stuck in the skull, then definitely the neurosurgeon needs to come in. And then the eye is the least of the importance, because we need to protect the brain now.
Okay, true. Okay, next one is, does tranexamic acid require, wait, let me sure.
Tranexamic acid, normally in chronic bleeding, you use it not for acute. Immediately when bleeding, you give tranexamic acid, it will not stop the bleeding immediately, right?
Yeah.
Yeah.
I don't think it was, it's more like direct pressure. I mean, in normal
Yeah.
circumstances.
Yeah. For chronic prolonged bleeding, yes, we use tranexamic acid.
Okay.
Okay.
Okay. Is that all, Alston? The question, that's all right. Any more? We got maybe 1 or 2 more minutes.
Boleh.
Later on, I will discuss what us, we as a team doctor or we are first responder, what we're supposed to do when we observe the players suspected having concussion on the field. You see, got challenge, direct knock to the head and fall down to the ground. Okay, you see this one, the second player. The keeper, you see that? Right? He challenged with the player, right? And then he get knocked direct to the head. Right? So this is the symptom that he complained. Alright, you see the goalkeeper there? He tried to save the ball actually and get hit direct to the goalpost there. You see the reaction of the goalkeeper after he get hit? Okay, this is a Drogba, challenge in the air and lost his balance and fall down direct to the field. All right. All right, now the challenge start to hitting the ball. You see the reaction of the player, no response at all. Direct head-to-head contact. Right, you see they got direct contact with the goalkeeper there. Direct to the head, no response. You see there's a bleeding also came out from the mouth. All right. I will share with you how we deal with the player suspect concussion later on. All right. All right. Enough with the video. All right. I want to ask all of you. All right. This now I show the rugby video, rugby games. Okay. So I hope you can recognize how does the player get injured and what's the mechanisms. This is very crucial as we are the witness, as a doctors, as a physios, as a team management, or even referees and spectators, whether this player is injured or not. Concussed or not.
He puts a high one up. Chasing this is Johnson. It's a big collision.
For Emery, he's going to be in a lot of trouble because
100%.
he has.
You see the direct challenge on the air, fall down.
It's a minimum yellow card.
The neck direct hit to the ground.
Very, very.
Yeah.
You cannot get more dangerous than that. That is very close to a major neck injury. Look at that. Wow.
Yeah, it's very dangerous act of foul play.
So the opponent, they got the red card to the referee.
Who gets some kicks.
All right, you see again here. Challenge the ball in the air. He got hit. Okay, to the lower limb, lower part of the body. Not direct to the head, actually, this one.
Every time Brian touches the ball. And I think the treatment will be watch out.
Okay,
Go
you
the
see?
legs. Oh, down he comes, rather awkwardly more than I suppose harder. Banner, that's a shocker. Yeah, there's plenty of grass.
Okay, the next one is during workout, I think. During the series, yeah. You see the player this one get direct hit to the head and fall down. No response after the hit. You see that?
Jumping into the air and he hits him, whether it's deemed deliberate, it's definitely a penalty. I think what he's got to worry about is it a yellow card. Number 6.
Right, yeah.
Playing an advantage. Barrett goes with the flat kick for
Yeah, again, this one, the challenge on the air. So the opponent try to get the ball.
It's going back to the penalty, but it's another drama on this side.
That didn't look good. I thought
You see?
Williams had caught the ball and then Naholo hit him. Let's have a look. Yeah, he really
Not
needs to
direct
be
to the
careful
head,
there,
actually.
Naholo, because he catches it first.
He try to challenge the ball, yeah.
It's tight. It's a
Lost
contest,
ball
though, Chief.
balance.
Now that we've seen it that slow,
And
I think it's fine. He was
fall down to
genuinely
the
going
ground.
for the ball, and they're both in the air. Yeah, he leaves the ground, Naholo. It's fine. No problem. Not nice, though. It's pretty nasty for both players who are still down.
All right, so we all know already in terms of the mechanism of the injuries in concussion, only two types, whether it's direct blow to the head or indirectly, all right, from any part of the bodies. So now we move on to the who are at risk of having concussions. So you can see in the pictures there, even this girl also suffered concussions. Okay, not only the players. All right. So based on study has been done, okay, the players over the age 30s and the players under the age of 18s are more prone to have concussions. And the players with 2 or more concussions within the preceding months. And apart from that, the player with history of multiple concussion happen, or with each subsequent concussion occur in less concussion happen. All right. And then the last one, the player with unusual presentation or prolonged recovery, especially in children's and also in adolescents. All right. This picture, we went to Brunei in 2018. We managed to get a champions for the Asian Rugby Women's 7 trophies in Brunei. So you can see there, one of our players, I think got 2 players suffer concussion during this game. All right. And you see this on your left hand side, top, there is our captain actually. She always wearing headgear in any tournament, in any games. So part of the prevention of the concussion. So how to recognize concussion? We are as a team doctor, team physio, how we want to know whether the player, our player or our athlete suffer from concussion or not. Okay, if you can see the pictures there, this one in, I went to Laos in 2017, if not mistaken. So you can see that even we need a good team and then good, well-trained team, medical, to handle any sport-related injuries on the field. As you can see, there is a doctors there even wearing white coats going into the field. And it's very important to educate our community, especially in medical personnel, to have a good qualification in terms of the sport coverage to deal with the sport injuries. All right. So what you see on the field, just now we go through all the video, all right? So lying motionless on the ground, the players lying without movement after get hit, whether direct or indirect. And sometimes we can see the player, they slow to get up off the ground after getting hit. And you can see the pictures there, the grabbing or clutching of the head. So what you see here immediately on the field, this is very crucial. So is there any seizures occur immediately after getting a hit? Is there any loss of consciousness? Unsteady or fit or balance problems? The player got confused, disorientated, dazed, and there is any behavioral changes after getting hit. So in terms of the symptom of concussion presentation, so there are many symptoms which include physical symptoms, cognitive symptoms, psychiatric and behavioral symptoms that can manifest a part of the symptom of the concussions. So every players, the symptoms are unique. We cannot rely on the specific symptoms and we diagnose the concussion. So some players, they just presented with the one symptoms. Some players, they presented with the multiple symptoms at the same time. These are the symptoms that can occur when the player sustains concussion. So I divided into physical symptoms, which are headache, blurred vision, the nausea, dizziness, sensitivity to light, nose, smells, fatigue, and muscles. And cognitive symptoms, inability to think clearly, confused, feeling slowed down, inability to concentrate, inability to retain new information. In terms of emotional symptoms, they are easily irritated, sadness, emotional imbalance, nervousness, and anxiety. And last but not least is sleep symptoms, unable to sleep. All right. What we do on the field, this is red flag sign we need to observe, and we need to remove straight the players out of the field. So anything related to the neck pain or tenderness, player complain having double visions, weakness, burning in arm or legs, severe headache, seizures, loss of consciousness, deteriorating conscious state, vomiting, and increased restlessness, agitated. Okay, these red flag signs we need to be aware that something more than concussion might be happen to the players. All right. So at the same time, in terms of observer sign, what we see to the players, whether from our on ice or sometimes from through the video. So the player lie motionless on the playing surface. They have loss of balance, get difficulties, disorientation or confusions, blank or vacant look, or facial injury after head trauma. Sometimes we see the players, they are having a very bad facial injury or laceration injury over the head. So you need to suspect and suspicious and to further investigate in terms of concussion and for the other traumatic brain injuries. And what I usually, our team practice on the field, we will ask the memory assessment method questions. There are 5 questions that usually we ask. All right. So, what venue are we today? We ask the players. Which half is now? All right. And then who scored last in the match? In this match. And then what team did you play last week? Did your team win the last game? So out of the questions, they're supposed to answer all the questions correct actually. So as you can see there, the video there, I have interviewed, I have did the assessments, one of the players who sustained concussions and he cannot answer most of the questions. The next one, what we assess actually the player's GCS. So we go for eye, verbal, and motor, and at the same time we assess the cervical spine assessment. So we ask the player, is there any neck pain or not? All right. So what we can see on the pictures there, our first responder there holding the head, and then the team physio. This is the team from Singapore. And they assess the players, do the assessments on the field before they remove the players out of the field. So we settle on the field management assessment. So we move to the off-field assessment. So in off-field assessment, there are a few steps that we fill out the form. The first one, in terms of athlete background, we fill out all their details. Plus, we ask about in terms of how many diagnosed concussion has been in the past. So at least we know the athlete sustained concussion before or not, and when the most recent concussion happened to the athlete. Because some athlete, they are playing the games with the club, with the university, with the state back to back. Let's say if they sustain concussion there this week, the next week also they play another game. That's why in our Malaysia Rugby Medical, we have a data in terms of every athlete, if they represent the state or represent the club, even represent the university, we can trace whether the club, the athlete sustained concussion or not, the game, last week games. So for the next week, we make sure they are not playing with the teams. All right. And then apart from that, we will ask the player in terms of symptom evaluation. There are 22 symptoms. So the player will fill up all the symptoms. The symptom can go from none, mild, moderate, and severe, with total symptom of severity go up to 132. So this player sustained concussions? This one actually, we just came back from SEA Games in Philippines. We're waiting the flight and the players at the airport actually. All right, we move to the step 3. We screen the cognitive function of the player. We have the orientation, we have the immediate memory. For the orientation, we ask about what month is this, what's this, today, what's day of the week, what day is this, what times right now. So basically, the player will answer all the answers correct. And then we have the immediate memory. We will choose. Okay, there are a few words there. So we will choose. Okay, which list we want to take. For example, I take a list A. So we tell the player, and they will repeat back whatever we are saying. For example, finger, penny, blanket, lemon, insect. So after that, they will repeat that. So make sure all the repetition that the player did, all are correct. The next one, we move to the concentration assessment. We ask the player to tell us back what's the numbers what we're telling. For example, okay, they have a list A, list B, list C, list D, list E, and list F there. So basically, I will put choose one list. Okay, for example, from list A, from the third digit until to six digits. So I will tell the number 1, 2, 3. The player will tell the backwards 3, 2, 1. This is part of the assessment. And last but not least, for the concentration, we'll test for the months in reverse order. So they will tell us from December up to January correctly. And the step number 4, what we'll do actually, we search the neurological screening of the players. So okay, we ask the player to read the instructions from the symptom just now, okay, to read whether it's correct or not. And then we do the passive cervical spine movement, and we test for the double vision and finger nose coordination. And last but not least, we ask the patient to perform the tendon gap, make sure they did a tendon gap normally. And the last, for the neurological screening, we do the balancing examinations. We ask player to do the double leg stance, single leg stance, tendon stance, and we look for the errors, how many errors. And the last step is a delay recall. We ask the player back the words, 5 words that we asked before. So if they can recall all 5, the score is totally 5/5. And in terms of the decision, after this, we complete all the SCAT assessment. This is the domain where we look for the symptom-wise, the severity of the symptoms, the orientation, the memories, the concentrations, the neuro examination, balance errors, and delay recall. So based on all the assessments, so we will decide whether this player sustain concussions. And then after that, we will remove the player totally out from the game. So no matter what, any argument from the players itself, from the coaches, from managers, even from the parents, we stick with our decision. The players sustain concussions. That's why we implement in Malaysia right now. All right. So how I want to share a little bit how our Malaysia Rugby Medical we manage concussion on the field. This picture we took about 2 years ago. We did the level 2 immediate care in rugby. So which involved in most of the country in Southeast Asia. So we shall in KL every year. Once a year we will have a medical super week. These are the courses that we can anyone for level 1 can join, including the parents, the players, the coaches, the managers, the management, to join the course, level 1 first aid in rugby course. This one basically we are doing before COVID, we are doing at least about 6 to 7 courses a year for this one. And then for the level 2, we will do the once a year in KL, and the rest we will do in Singapore, in Hong Kong, in other places. All right, these are the example of the certificates. While we did the test, we get the level 1 first aid in rugby certificate, and then for the level 2 immediate care in rugby, we get the certificates. And then the additional one, if you are very, very interested, you can go further to be part of an educator for the World Rugby, to teach for the level 1. And then some of my colleagues in Malaysian Rugby, we have a recognized part of the World Rugby medical trainer. What we do before the game, if I going out with the team in any tournament, in any games, we need to fill up a medical player summary. So every player, we need to fill up all the medical form. So at least the tournaments organizer, tournament medical organizer, they know what are any medical issue related to our players. Apart from that, okay, this is the form. We can fill out all the allergies, medication, past medical, and then we will conduct a baseline SCAT 5 assessment to all the players that going with the team. 5 to the players during the games, we can see in terms of the scoring because we got a baseline already. This is what we are practice actually. And during any games, any tournament, okay, for the rugby, we have a tournament medical director who oversee all the team of the medical. We have the match day doctors. We even have a concussion doctors. We have a first responder, and we have the paramedic to help us. And we have also nursing also as well. These are, for example, what our team during the last Asian Rugby Championship, which is in KL, Malaysia versus Hong Kong and Korea, if I'm mistaken. So we have the doctors who lead, and we have the immediate care lead, and then we have the paramedic teams. And what we do actually before the games, you can see we have a complete the time schedule there. Even we need to be there by 6:30, and the kick-off game actually about 8:40. So we do all preparation, all the briefing. We meet both of team doctors. We meet the match official, the referees, and then we do all the training before before start the game. So this is our team actually, which consists I think got 3 doctors there, plus paramedics, nursing, and also physios. These are what we are doing. We are briefing, we are demonstrating, and then we are checking all our equipments just before the games. Because we know if we are playing, let's say the team from outside, from the Hong Kong, the Caucasian mostly, the players, they are big, we need to get a suitable equipment for them. This is our team standby. We have 2 teams side by side actually to taking care if any players from on the field. Okay, still have a few minutes.
A few more minutes, Nick. Yeah.
I should say the video, what our experience. This one happened in last Terengganu before the COVID last year, last 2 years. That's why it's very important to us as a medical provider to know what is our role on the field. Okay, we have the first responder holding the head over there. We have the one with the beeps is the team doctor actually. This is my colleague also, he got a level 2. And then there's the match day doctor is Dr. Zul, who are taking care of the team. Now they are trying to educate the players, okay, diagnose concussion on the field, and then we try to remove the players out of the field. So they check everything in terms of the collars, in terms of the strapping, everything, and then they remove the players out of the field. And the movement also, they start move from the toe, and then followed by the head. That's on. Okay, this is also one of the our team during the Piala Agong. All right, we have a complete team there. And how we deal with the player with concussions. So when we recognize the player with concussions, so by a medical first aid attendant, so we remove the player from the field, and then we record the player, and then at the same time we conduct all the 5 assessments, and then whether the player need to refer, we will refer player to the hospital if needed during the games. And we have our own form in terms of the injuries and concussion referral form. So in terms of advice to the players or to the management in terms of when the player can return back to play. Okay, that one I will explain further later on. And then in terms of clearance approval, the only doctors can allow the player do assessments before go work to come back to the field, come back to return to play. All right. When to refer our player actually to the hospital? The first one, the player complained of severe neck pain, and then deteriorating consciousness, the player confused or irritability, severe increasing headache, repeated vomiting, unusual behavior, seizures, double vision, weakness, burning in arm or legs. So why concussion is difficult to diagnose? The first of all, because there is no definitive diagnosis of the concussions. So when we did the MRI, X-ray, CT scan, all are normal. And there is no visible injuries in concussion. We don't see any broken bones, any bruise or any bruises. Okay. And then the symptom of the concussion can take weeks, months to may appear in stages. And many concussion symptoms can also occur due to other causes. And concussed individual may not recognize or admit having symptoms also at the same time. And there's a false belief that one has to lose consciousness to have had a concussion. Okay. How to return back the player to the field? We have what we call graduate return to play protocol. This one we have been practiced for so long times. In terms of one, we diagnose player with concussions. So we will follow this step, the player to go back to the return to play. Okay. There are 6 stages for the GRTB program. The stage 1, minimum rest period. Stage number 2, light aerobic exercise. Stage number 3, sport specific exercise. Stage number 4, non-contact training drills. Number 5, full contact training practice. And return to play. And we allow player to play. This is a poster that have been done by World Rugby. So they have shown there. So the earliest time return to play, for example, we divide into 2 ages. Different age, under 19, after 19 days completed the RTP, the players can allow to return to play. And for the adults, more than 19, after 12 days, after completed the graded return to play protocol. All right. So how does this process take? Actually, it can take many days to progress about one step. So we cannot assume after complete stage 1, the player can move to stage 2. No. So that's why if anything fails, stage 2, we need to go back to the stage 1, to the players.
Sorry, Nick, sorry to interrupt. Just wondering how long is your talk going to be?
This is my 2 slides.
Last 2 slides. Yeah, I can see many interesting questions coming up.
For concussion, is a brain injury. No matter what happened, concussion is a brain injury. So concussion requires specific treatment for fully recovery. There is no such thing, no normal CT scan, no symptom, we can return to play. No. Recovery from the concussion begin immediately after having concussion. And then there is increased risk of concussion if fully recovery from a previous concussion was not completed. So I think that's all for my slide for today. And for your information, for the I just promote Malaysian Rugby Medical Symposium will be held in September this year. We still have a few slots available, and we have 2 days course. The first day we have a full talk all about injuries in rugby, and then the second day we have a workshop for the level 1. We have the tapping workshop as well. I think that's all from my side. Thank you. Let it go. I pass back to you.
Okay. Thank you, Nick, for your sharing of your vast experience and bringing the field to our webinar today. And I think you are a bit underdressed compared to the Laos doctor. You should bring your white coat too. Anyway, we have got a lot of interesting questions. If you can very quickly go through them, because we got only 10 minutes. To how many questions we have, Chong, in your PowerPoint?
About 10, but we will stop when we already reach the time.
Okay, sure. So we have 10 questions to address. If you can, I think it's good to have all 10 answered. Okay, so yeah, question number 1, does women have higher risk of getting complicated concussion? Why is that?
Yeah, based on study done, woman is getting higher risk having concussions, and then the younger age as compared to adult also in higher risk. It's because mainly the woman in terms of the experience wise, and then in terms of readiness to play in any sports, not only rugby, in any contact sports, they are prone to have a concussion. I think more than men.
I see. Okay, just because of experience, huh? So we must be more experienced. Okay, number 2, any differences between the diagnosis and management of concussion in between the athletes and general population? Do you manage them the same way or diagnose the same way?
Yeah, basically it's same actually. That's why there's the process of the diagnosis. Example also, the children fall down from the playground also, we can, the diagnosis is the same. That's why the issue is that when we bring to the emergency, we did diagnose a concussion, but we don't know what next to do to any athlete or any general population. That's why I have shown to you what in terms of the return to play or return to normal after sustained concussion. There are a few steps we need to follow, and then we need to follow, and then approved by the doctors before we go back to play or normal activities.
Okay, so number 3, is there any serum biomarkers to predict concussion? Maybe someone will be asking about genetic as well, I don't know. Or any biomarkers to give prognosis of the concussion progression?
All right, so there are many studies have been done about all the related the biomarkers actually. This is a master student question, I think.
Trying to get a shortcut.
There is no definitive biomarkers that we can say this is when positive, these biomarkers, we diagnose concussion, no, so far.
Okay, the 4th, what are the role and when should we order imaging studies or electrophysiological testing in patients with concussion?
That's why the diagnosis is very crucial. The second one, in terms of red flag sign, I have shown. That's why any games, any tournaments, we need to know when we need to refer our players. Not all the players will refer to the emergency. That's why the result, we get unnecessary referral is it's not good. I mean, actually for our colleague in emergency. That's why we need to know when the player we need to refer. That's why we need to have a specific qualification to decide whether the player need to refer or not.
So not all concussions will be referred, is that what you're saying?
No.
Okay. Okay. So next question, Chong. Okay. Okay. This is like a personal experience question, I think. I'm an ex-rugby player. One of their teammates have had a history of forgetfulness during rugby games. Usually happen twice a year. But he has no obvious head concussion before. Sometimes he even forget where he is. What could possibly happen?
So basically, this one we need to go back to the past histories. Actually, we need to check also because since he played rugby and for sure he get contact, got injuries. So that's why I have told you, I've shared with you the videos before in terms of the concussion. It's not on the spot we got the symptoms. I mean, in terms of the complications, that's why it can happen after you retired from playing rugby, 10 years, 20 years after that, it appeared the symptoms or the disease. Yeah. So need to be check on further on it.
So it's still possible that he has a concussion that has not been, observed or diagnosed, identified, right?
Yeah, correct. During the games before. Yeah.
Okay. Punita is asking, how soon should you do the off-field assessment? And is it immediately after removing the player, or when do you repeat it?
All right. Usually I will do the assessment once we remove the players, and then we'll do the primary survey. After that, we proceed with the off-field assessments at the medical tent.
So when do you repeat the assessment again?
Basically, the step 5 actually we want to diagnose the player with concussion or not. All right. If there there is another assessment what we call head injury assessment. I don't want to discuss this one more complicated. That one more complicated version actually. That one more different. This one I think what Punita said. I think in terms of repetition for us. For the step 5, usually we will do assessment once the patient out of the field. Yeah.
Okay, so you do not repeat it? Is that why?
No, unless in terms of return to play, that's why we will see in the clinic later on in terms of whether we need to clear the player from can return back to play or not.
Okay. Next one is a neck muscle strengthening that can help in preventing concussion.
There is okay. I can say specific what type of neck strengthening that can prevent concussion, because that's why I go back to our basic mechanism. The players get injured from direct or indirect. So any part of the body can contribute to the concussion. So there is no specific muscle.
Mm-hmm. Okay. Okay. What is it? Often when players sustain concussion, there appears to be no cervical protection. Oh yes. In a few of the videos shown, you know, the players were immediately handled by their teammates and referees. What are your comments without, you know, cervical protection being done? What are your comments?
Yeah, that's why actually the management in terms of that is actually not correct actually. So that's why we need a good medical team to be on the field anytime, so that we know what we are supposed to do to protect the players from the field outside the field. So whatever the video is said, I showed just now, there is the players, the referee with no experience, they're not supposed to be part of the team to manage the players with concussions.
So is it not part of the requirement for referees to know how to manage concussion to be, you know,
That's why
qualified?
for rugby, most of our rugby referee, they going for level 1 at least. So level 1, they know already what's supposed to do if suspected the player sustain concussion. How to do the manual inline sedation, or how to secure the neck before the paramedic came in with all the equipments and the cervical collar.
Okay. Is there any association between sports concussion with chronic traumatic encephalopathy later in athletes' life? I think you might have answered somehow, but maybe you want to elaborate more?
So the answer is yes, actually. So that's why once the athlete got concussion, then later on when they are retired, that's happened in American football. That one that they counter, got few athletes suffer from chronic traumatic encephalopathy just because of the impact of the concussion.
Okay. Children with concussion managed differently?
All right, yes. In terms of the recovery and the return back to the sports, the time frame is longer. For the adults, it takes about 12 days. But for the children below that 12 years old, 19 years old, it takes about 3 weeks.
Okay, so it's the duration that differs, right?
Yes.
Okay, okay. Oh, someone is interested to register for World Rugby Level 1 course. What's your advice?
Okay, we open to anyone, actually, anybody. So we not limit to the rugby only. In any sports, you can come and experience how we deal with the first aid in rugby. So how we'll deal on the field, what we are doing on the field. So the course basically, you can go to Malaysia Rugby Medical. We have the IG and also Facebook, and also Malaysia Rugby Union Facebook page. So we have listed all the costs that throughout the years. Yeah.
So it's recognized not only by rugby and can be by any professional sports body.
Yes, correct. So I mean, that's why we have idea what's supposed to do on the field when there is a concussion or any neck injuries. All right.
Okay, thank you. If there's no more question, we will thank Dr. Nick for his sharing. And yeah, we just finished on time. Thank you very much for your sharing, Nick, again. If you have any pearls to share with the athletes before you go, with the participants before you go, since
if you have any queries, you can email me drnikmru@gmail.com. So, or my Facebook, Nick Haziman. So you can discuss anything doubt related to not only rugby. Yeah. Thank you, Dr. Go.
Okay.
And then thank you for having me today.
Thank you for joining. Yes. Thanks, Nick. Okay. Now, we will move on to our next speaker. Last but not least is a speaker who is also very experienced in the topic that he's going to talk about. Is Dr. Azamani Muhammad Idrus. Is currently the consultant emergency physician at Hospital Kuala Lumpur and also heads the pediatric emergency department at Hospital Tunku Azizah. Do you believe that he has got a PhD in mountain medicine, and he represents Malaysia in the medical committee for International Climbing and Mountaineering Federation. So he will be talking about mountain sickness. Over to you, Dato.
Thank you, Dr. Go. Let me put my slide on. Just one second. Just one second. Okay, just 1 second. I'm trying to get it on. Yep. Is it shared? Can you?
Yeah, it's shared.
You share? Yeah? Okay, that's good. Just 1 second. I'm just trying to slideshow it. Okay. It's processing. Yeah.
Yes, not yet.
Okay.
Coming good, great.
Good. Good.
Okay. So shall I start?
Yep.
Okay.
Yes, please.
Thank you very much. It's 12 noon. It's me standing between you and your lunch. So I will be talking on the topic of high altitude emergencies. So I've got a lot of slides, but basically what I will do is just to take you on a tour to Mount Everest. So I'm gonna walk you through and climb with me at least to the base camp, and also from there with the climbers bring you to the top of the mountain. So all right, so okay, just let me see. Okay, moving on. Okay, so the Everest. Yeah? So we all know this is the highest mountain in the world, and it's beautiful. And this is actually the view of the mountain from Tibet. There are two routes. If you want to climb the Everest, you could climb it from the south route through Nepal, or through the north route through Tibet. From Nepal, you can't really see the top of the mountain, but from Tibet, you can see the top of the mountain over there. It's like windy up there if you look. And it was conquered in 1953 by Sir Edmund Hillary and Tenzing Norgay. But do you know that there was this guy 30 years earlier than Edmund Hillary's quest? His name was George Mallory. He attempted to climb Mount Everest from the Tibet route. And actually, you could actually look at the top of the mountain from Tibet. And one of the expedition team, they looked through the binoculars and they found that they were these two climbers, actually George Mallory and another one by the name of Irvin. They were almost reaching the summit, and then suddenly they were shrouded by clouds, and they were never seen before. After that, never seen ever again after that. So it was a mystery whether they actually got to the top of the mountain and then on the way down, died, or they actually died before they managed to go to the mountain. And there are some people who actually believe he did. So that's the photo of George Mallory and the wife by the name of Ruth. And George Mallory was a family man, and he brought the photo of the wife in his jacket, and his aim was to leave that photo on the top of the mountain. 70 years after George Mallory was lost, the body was found in pristine shape in Mount Everest by some Chinese climbers. And the thing that they hoped to find was the Polaroid camera, which would have showed an evidence that he actually reached the summit, but they couldn't find it. And also, they also didn't find the photo of Ruth in his pocket. So it's still a mystery. But what I'm showing here is an Everest story. And at high altitude, there are a lot of problems that you could get. Like this is a trauma, and more than 300 people died in their quest in trying to conquer the Everest. So if we look at where we are, Kuala Lumpur, we are actually standing at 60 meters above sea level. If you go to Genting, you could get at 2,000 meters. In Cameron Highland, about the same height. And the highest mountain in Malaysia is Mount Kinabalu, standing almost 4,100 meters. If you want to climb the Everest, you got to get to the Everest base camp, and that itself is actually higher than Mount Kinabalu at about 5,300 meters, and Mount Everest stands at 8,848 meters. So these are the risks that you can get if you get into mountain climbing. It's a high risk. You may get trauma, you may get snow blind, you may get acute mountain sickness. If you go to cold countries, you may get frostbites, hypothermia, and get affected by avalanche and storms. So these are the challenge that we have. You can't carry an ambulance, or if you're in trouble in the mountains, an ambulance cannot get to you. And if you're in trouble too, there are no nearby facilities. The facilities may be like kilometers down from the mountain. And if you bring drugs over there, they may crystallize because of cold weather, crevices. And doctors themselves, if you climb the mountain, you are also human and subjected to high altitude illnesses. And there are avalanches every day. If you're at the Everest Base Camp in Nepal, at Khumbu Falls, you will see avalanche when you're at the base camp falling down. So these are the things that you have to do. You have to train, you need to plan, you need to prepare medications, equipments, and you have to modify and be flexible in providing care for the climbers. Get good insurance, good mountain boots, because sometimes along the way there's water and it's cold and you could get frostnip or frostbite. Get a good down jacket, a good windbreaker, usually made of a good down jacket made of goose feathers that can keep you warm. Good sleeping bags that could withstand a temperature of as low as -20 degrees when you're sleeping on a mountain as high as the Everest. Good sunglasses, very important. I will tell you why after this. And I think get yourself a good MP3 player and listen to the music. And I'll probably also tell you why. Okay, this is taking you through the south route. We shall go to the Everest Base Camp together. Let's travel there to Nepal. So this was me. This was many years ago. So we took this plane, Royal Nepal Airlines, to Kathmandu. Royal Nepal Airlines had two airplanes. And we were told that when we went there, one of the planes was out of order. And by the time we landed, that plane also was out of order. If we missed that plane, we would never be there. But nowadays there's Air Asia, but of course with the pandemic, all this stopped. From Kathmandu, you have to travel on this small plane and get to a place called Lukla. And from Lukla, you've got to be on foot for a period of 9 days to get to the Everest Base Camp, which is here. Okay, so I'll show you what Kathmandu looks like if you haven't been there. Yeah? So this was me. So with good sunglasses, I got my pouch bag because this is where I put my simple medications to help the climbers. Good boots that could hold, that could stand cold waters along the way. This was the town, the Kathmandu town. You find that in Kathmandu there many people can speak Malay language. You go and buy things at the shop, they will say RM5. Apparently there was one village whereby everybody could speak Malay because all of them had worked in Malaysia before. So it's quite an interesting place to be. You even find this Perodua Kelisa on the streets there. So, okay, from Kathmandu, you fly to Lukla, and Lukla itself is 2,800 meters. That's quite high by altitude. So arrive on this plane, and then the airport is also, it's not level. You look at the airport, it's slanted, and at the far end is actually a gorge. So a plane landing, the pilot has to adjust the plane so that it lands, parallel to the airstrip. And there had been air crash in the past. So this is little village in Lukla. You'll find all these Sherpas who actually that's how they make money. They help the tourists to carry stuff. And this is what it looks like on the way to the base camp. So they'll be carrying this stuff like this at a price, of course. So these were us. We were a group of support climbers for the Everest climbers, Malaysian Everest climbers. And we go through all these valleys and to find our way at multiple lodging houses. So I would show you the case number 1, because along the way, this is how I would relate the high altitude illnesses by experience to all of you. So this is a case 1. We had a 24 years old Malay gentleman, very fit. He works at the in the gym at the sports science school, and he ascended very fast. Every stop, he was the first to get to the stop. Very fit guy. So we reached at a level of about 4,000 meters, and he was well initially. 4,000 meters is equivalent to Kinabalu. 8 hours later, the oxygen saturation dropped to 79%. But when I listened to the lungs, they were clear. There were no crackles. But he's got these symptoms of very bad headache. He felt fatigued, weak. He can't sleep. He even vomited. He had abdominal pain and shortness of breath. So all these are very classic signs of acute mountain sickness. You are on the mountain and suddenly you have this sickness. You're sick. And usually, typically, it doesn't come immediately. After you get to a level, after resting a couple of hours later, you start to develop these symptoms. So that is very classic of acute mountain sickness. And actually, if you vomit, that's not a good sign. That is actually equivalent to being to a severe acute mountain sickness, or AMS. So it was so bad, I had to give more than one type of painkiller. The Panadol, the paracetamol alone didn't cut it. And for the MS, I had to start the acetazolamide and also added some steroids on top of that. And he felt much better. He was able to walk. And actually, the treatment on the mountain is, when you are sick, is about sending them down. Send them down. And that is the definitive treatment. Because lower down is the place where you will get the oxygen. So when you got down 1,000 meters lower, there were no more symptoms, and he was well after that. Now, it's a tough decision, because sometimes without treatment, they would be really sick, and to get them down, you have to carry them. So if you could treat them enough for them to walk, that would be a huge relief, because to get one person down on the stretcher, you would require 4 persons. So that's not good. So for the rest of us, we continued our journey through all these rocky pathways. And I stopped at a lodging house and slept there with my team. There at the lodging house, I met a 32-years old Filipino doctor. He was the team doctor for the Filipino climbing team. And he had not been feeling well since I first met him at a place called Namche Bazaar, which was about 3,000 meters sea level. And he already took acetazolamide, which is medication for acute mountain sickness, and he felt better. And he ascended further to a place called Lobuchi. It's about 4,000 meters. And at night, he developed severe headache, the drop with the oxygen oximetry, oxygen saturation, but he denies having any GIT symptoms. He was not vomiting, and he was also not having shortness of breath, just a plain, very bad, severe headache, which can be scary. If you get that kind of patient down here, you will already think this patient may be having subarachnoid hemorrhage, for example. But up there, first is a diagnosis is AMS. And I was woken in the middle of the night by the Filipino team from sleep, and they asked for help. So again, he's also had acute mountain sickness, not with other symptoms. This is purely the headache. Yeah? So he already took the acetazolamide. So now to treat the headache is a bit tricky in this doctor. He was allergic to NSAIDs, opiates, and also paracetamol. So I can't really give him Ponstan, I can't really give him the tramadol, and I can't give him a paracetamol. But luckily, I got a tablet atorvastatin with me, a COX-2 inhibitor, and I got some steroids. So I gave them this, and he was better after that. The oxygen saturation improved. I was observed by a male Filipino staff nurse who followed him, and he was well the next morning, and the saturation improved, and there were no more symptoms. He went down after resting for another day at that height because there were no symptoms, but he went down, and then he climbed back up again and got to our base camp about 4 days later. So if you look into acute mountain sickness, in understanding what causes acute mountain sickness, it's basically simple. The mother of all these problems, of all these symptoms, is just one, which is basically hypoxia, low oxygen, which physiologically speaking affects all parts of the body. So we have a same oxygen concentration at high altitude, still 21%. But the problem at high altitude is the low partial oxygen pressure, meaning that each inhalation or inspiration of oxygen, less oxygen will come inside your body because there's less pressure, less entrance. You have to inspire harder to get the oxygen in. So as a result, your body in a state of hypoxia. So initially, your body, when in a state of hypoxia, your body responds from the respiratory center by making you hyperventilate. You breathe in higher frequency, but when you do that, you are kicking out the carbon dioxide from your body. This carbon dioxide is important to preserve the state of normal pH, body pH. But when more carbon dioxide goes out, more alkali goes out, it leaves your body in a state of respiratory alkalosis. So the CO2, the acid goes out. Your body is relatively in a state of alkalosis. And because of this, the respiratory center is telling you stop breathing too fast. Just breathe normal or breathe less. So with that happening, the problem of less oxygen in the body become worse or perpetuated or worse. And CO2 also stay in the body. And this brings about the symptoms of acute mountain sickness. If you look at this busy slide, it's actually what happens physiologically speaking when your body in the state of hypoxia. All vessels in the body become vasodilated. They become dilated, except for the ones, the capillaries in the lungs. That is physiology fact. When you have vasodilation in the brain, for example, the vessels dilate, that would cause a throbbing headache. Not only that, with the state of hypoxia, there is also production of, like, for example, bradykinin, some chemicals, biochemicals in the body that cause increased permeability of fluid. So the capillary, they become more porous, and fluids go out and accumulate. They accumulate in the brain, and that can cause a high altitude cerebral edema. It could cross and accumulate in the lungs and cause what we call high altitude pulmonary edema. They could cross through the skin and causing your face, your legs appearing swollen. So all this, stem from the simple problem of hypoxia. So when it's not too bad, it doesn't cause brain edema, it doesn't cause pulmonary edema. It may just cause those symptoms because we know when the increase of pressure in the brain, a classic pressure, increase of intracranial pressure is like nausea, vomiting, headache. So headache is the classic point of the AMS usually, and the rest too can follow suit. Yeah. So now you need to be acclimatized so that all this acute mountain sickness would not come to play. So, so what we mean by acclimatization, number one, you need to climb slowly for your body to adapt. And when we say somebody is acclimatized, meaning that he's not going to get the AMS, it is actually a process whereby your kidney has learned to excrete more bicarb. Bicarb is alkali. When it excretes more bicarb, it causes your body in a relative state of acidosis. When your body in the state of acidosis, what happens is that you start to breathe deeper and faster. It's like having a Kussmaul's effect. But this is good on the mountains because it will draw the oxygen in and cause you not to have all those effects of hypoxia. So this is what we call acclimatization. And what it means is that you climb slowly, and also you have to give time for the body to adapt, which usually takes about 48 hours or even up to 3 days. So when you reach, usually this acute mountain sickness can occur as low as 2,000 meters. But when you get to that level, it is advisable for you to sleep at that level before you ascend further for at least 2 nights. So these are the symptoms I've illustrated just now to you, the classic symptoms of that young chap who climbed the mountain, and also the doctor. And you could actually self-diagnose by using this Lake Lewis AMS symptom score. So a score of 3 or more on the questionnaire is positive for AMS plus. You have a headache. A score of 6 or more is equivalent to a severe AMS. So this is what it looks like. You could actually circle and count the score, and then you could make the diagnosis. This is based on a consensus by doctors of mountain medicine. So how to prevent? Actually, you climb slowly, not too fast, and you make your gains when beyond 3,000 meters, not more than 300 per day. 300 meters a day. And if you get to 1,000 meters, 300, 300, 300, you get to 1,000 meters, you have to sleep for 2 nights to again make your body adapt, acclimatize to this condition. So this is the thing, you need to spend at the intermediate altitudes before ascending further. Yeah. So you can also use drug prophylaxis in the form of acetazolamide. So acetazolamide is a cheap medicine. It's actually used, it's an antihypertensive medicine, also used for glaucoma. And what actually we want from acetazolamide is actually not the effect of the drug lowering the blood pressure, but it is more on the effect of its side effect. Because acetazolamide produces this acidosis. Metabolic acidosis, and this metabolic acidosis produces a Kussmaul-like breathing, a deeper and faster breathing, and that helps with the respiration. And you could use that if there's no way you could acclimatize. You have no choice but to go up there to rescue someone, or in the military, you have to go up. Then you can take this as prophylaxis. For prophylaxis, you could take as low as 125 milligram twice a day, but you got to start it a day before you climb. And when you get to the up there on the mountain, you need to at least continue for at least 2 days. And if there's still symptoms, you got to continue it until there are no more symptoms. So for those who are with the size of more than 100 kilo, you can take more than that, 250 milligram. Usually 250 is about a tablet. And it's just that if you're not that overweight, half of that will do, because it would not give you much of the side effect in terms of metallic taste, diuresis. For pediatrics, it's the dose 2.5 milligram per kilo, also to be taken twice a day. But if you got the symptoms already, then you could take it 3 times a day. So basically, in treating AMS, if it is just mild is like a simple headache. You just need to rest where you are, and you can just take Panadol, and that's enough. But if it is severe, you may have to descend. This is when, if you have oxygen, you can have it. Oxygen is very expensive up there, because it's expensive to bring the oxygen tank up there. It can cost something like 600 US dollars. And you can take acetazolamide, and you can, on top of acetazolamide, take dexamethasone as well. If you have hyperbaric chamber, you could also use it. But if you can go down, you can just go down and you will get better with a higher pressure oxygen down there. So if I explain to you about HAPE, what it was all about, basically this is more towards the the extreme end. AMS is just more of a symptomatic discomfort. But once you get your lungs flooded with water, so you get, which is actually a non-cardiogenic pulmonary edema, you could actually die drowned with water in your lungs, although there's not a single drop of water outside. So this is what you could get as what called high altitude pulmonary edema. Actually, what happens is that with hypoxia, the vessels in the lungs become constricted. When it's constricted, then the pressure in the capillary, in the vessels are high. And coupled with the porous lining of the capillary, water goes out. So that causes the accumulation of water in the lungs. One can, they can cough, they can produce pinkish sputum, the lungs full of crackles when you listen to the lungs, and they can be diagnosed. So the treatment is still descent, but there is one thing that you could add, which is nifedipine, which is a calcium channel blocker. And what it does is actually to open up these vessels in the lungs and to relieve the pressure in the lungs, and that would help. Plus, if you have oxygen, you could give. If you have hyperbaric bag, you could give. This is the treatment. And some do take this preventive medication in the form of not just nifedipine, but also tadalafil and even Viagra, sildenafil. Some use this as an excuse to try Viagra. But this is just some prevention, and actually it's not as common as AMS. And this is actually an example of a hyperbaric chamber on the mountain, whereby you could actually increase the pressure by foot pumping this back. It becomes a hyperbaric chamber. There's a pressure gauge there, and you could breathe 100% oxygen in the bag, inside the bag. So, okay. So now let's climb further. Okay, let's go to the base camp. So this is about 5,300 meters above the sea level. This is what we call the Khumbu Falls. So as I said, from Nepal, you can't really look at the Everest. And these are just some small mountains, but not the Everest. The Everest is obscured. So this is Malaysian camp. You could see that the Malaysian flag. And this is a very important place, this greenhouse, which is actually the toilet. And actually, you cannot leave anything at the Everest base camp. There is a container, and when the container is full, it will be sealed and brought down. So this is where you are, and this is my tent. Every morning there's this Sherpa bringing warm water for me to brush my face, brush my teeth, wash my face. So, okay, while I was at the Everest base camp, there was a 64 years old Malaysian gentleman, and he descended down after training, and he got to Camp 3, which was 7,200 meters during practice. And I was there at the base camp, and I saw, as he was approaching the base camp, he was hit by an avalanche along with another Malaysian climber. They were lucky because they were just like 10 minutes earlier, and with that they were like at the tail end of the avalanche. Let's say they were 10 minutes late, they would probably be engulfed by the avalanche. That would have been a disaster for our team. So he survived the avalanche, and then as he got close to our tent, he took off the sunglasses. And then he developed a severe gritty pain in both eyes, and he can't see. He could only visualize light, and the eyes were red. And this was the Khumbu Falls, how it looks like as if they were coming down. Okay, this is all the photos at the Khumbu Falls near the Everest base camp. And this guy actually has what we call snowblind. The eyes just became blind from the reflection of the lights that came from the snows, the water up there. So I just gave him some symptomatic treatment in the form of lubricant and some iPads and something, because it's very itchy, the symptomatic for the itchiness in the form of chlorpheniramine, and I had to use different multimodal painkiller because the pain was just severe. So after all that, the pain subsided. He was could only be relatively more comfortable and could sleep. And we kept the iPads for 48 hours, and he was well after that and regained full vision. So this is snowblind. And basically what happened is that this is the layer of the conjunctiva has been burnt by high radiation reflected from the UV solar from the snow, the ice, and water on the mountains. So that's why it's very important to wear a good quality sunglass and not to take it off while you are surrounded by the snow on the mountain. Because up there, there's not much filtration of the UV light. So it disrupts the epithelium of over the cornea and the conjunctiva, and it could even cause retinal damage. Classically, the symptoms came 4 to 12 hours after exposure. In the case of our case, that gentleman, it occurs something around 4 hours after he ate his nasi lemak at the base camp. Then he complained this severe pain. So ideally, you could put cycloplegic, something to paralyze the iris muscle, and that could relieve the pain. But the downside of that, they usually it will be dilated for a couple of days, and the patients may complain that the vision is not returning. In this case, it's about gonna climb back up soon because the window can open at any time. So I didn't use any cycloplegic. Plus, I didn't bring any. I didn't have any in my with me. So these are some of the medical preparation. After this, we had to prepare to help the climbers by telemedicine, meaning that through the walkie-talkie, when they're in trouble, I would just give them instruction and give them a bag of drugs that they could take. So this is what we practice by anticipation of what they may have. The problem of AMS, HIP, HAZE. Beware that we do not know. They may get acute coronary syndrome up there, asthmatic attack. A lot of them got this cough because of the cold, dry air that they inhale, called the kumbu cough for months. Pain, well, even frostbite. So we had to keep some symptomatic medicine as well. So this is another doctor, my teammate, and we prepared the medication for the climbers and put them in a pack and let each one of them keep a pack. So we walkie-talkie with the climbers if they have any problems. In fact, when the window opened, the window means that there's an opening, that there's a chance for them to attack the summit. So the our Malaysian colleagues left, and while climbing, one of the climbers already walkie-talkie with him. She developed diarrhea, and I had to instruct her to take some supportive medications. So now we get to case 4. This is a day 2 of the final attempt to attack the summit. The same 64-year-old gentleman who had the snow blind, he took a bit longer hours to get to Camp 3, about 12 hours. And on arrival, he had an altered consciousness, became semi-syncopal, and was seen by, there were 2 doctors from UK at Camp 3, and they diagnosed him as having high altitude cerebral edema. And he called me, and he told me he has to go down now, and if not, he will die in 30 minutes. So, going down from a height of 7,200 meters at 6 o'clock in the evening is not a joke. It's not like you could get into a lift and press the button, ta-da, you are on the ground floor. No, that means not only him, he had to go down with some other people. It's going to be dark, exposed to crevasses, exposed to the cold weather, and again go through all those exhaustions. So I had to make a decision whether he should come down or not. So up there, he was given dexamethasone, acetazolamide, was put on full blast oxygen, and and he was told that he should go down. But after that, when I checked with the team, they said that after he took energy drink, he was well. And I asked, does he have any headache? He didn't have any headache. So that was the consideration. So this was what I worry if he goes down, and him being relatively elderly gentleman. So I noticed that he was well. He was fully conscious, no AMS symptoms. So I've decided that he can stay there on the mountain and come down tomorrow. So the question is that, is this a true high altitude cerebral edema? Classically, high altitude cerebral edema, they will have, yes, altered mental state, but also they can get syncopal, they could get seizure, they could get hallucination, but he didn't have that. And what is startling is that after he took the energy drink, he was very well and chatting with other climbers. So I attribute that likely due to exhaustion, or even probably hypoglycemia, because it was a long walk for him, or even dehydration. So this is high altitude cerebral edema, the extreme end of acute mountain sickness. So the treatment is steroids. I mean, apart from going down, oxygen, hyperbaric bag if you have. So anyway, he came down, but the rest of the climbers went up. The next morning, that climber walked down. He was actually the leader of the climbing expedition, but he said, it's all right. I do not want my other colleagues to worry about me. I would go down. So the 6 continued to climb. And on 21st May, 6 of them all summited Mount Everest. So not bad too for that old guy, because he reached Camp 3. And that is a record by itself for Malaysians to reach at 60, at his age, 60, 64, 62. And the most important thing is that all came back safely to base camp. Actually, there were other people who died. There were some Koreans who died during this activity. This is a camera view from one of our climbers up there on top of Mount Everest. So then we were waiting for them to come down. So I got this case file, 52 years old gentleman, a heavy smoker. And he was the first among all international climbers, it's our Malaysian, who got to the top on that day. And he also descended back first to arrive at our camp. And he complained pain over tips of the toes, and complained of numbness. And it was cold, cyanotic skin, you know. But there's also some decreased sensation over the toes. So he actually had a frostnip. Yeah. So along the way, it was cold. He was walking. So this is the what I did was soak the feet in warm water. And turn the water around him, put it on his feet, and then I give him some tablet aspirin. It's just to improve the circulation down there, and a small tiny dose of nifedipine just to dilate the peripheral blood vessels, and some painkillers. So he felt better. The bluish discoloration disappeared, but the toenails came off like weeks later. There's no more pain, just some persistence of mild numbness, but he was well after 2 weeks without any symptoms. So this frostnip is the first mildest form of peripheral cold injury before you actually get to what we call frostbite. So we just need to warm them up quickly. And if there is a persistence of freezing weather, meaning that are sub-zero degrees persistently exposed, you could get frostbite. And frostbite is just like burn, whereby you got a first degree injury. Initially, it's just some, redness. Second degree, you start to form blisters, and a third degree, it gets to all the subcutaneous, all levels of the skin. And the 4th degree gets to the bone. So it's just like a burn, but it's just a cold burn. But if it is persistently exposed to non-freezing weather above 0 degrees, then you could get what you call either chilblains or immersion foot. Immersion foot, more of water. You're immersed in the water, which is actually not sub-zero water, but chilblains is more of exposure of the wind and water. Anyway, okay, let's take you Everest via Tibet, because I had an opportunity to be as the expedition doctor from both routes. So this is Tibet. But 4 years later, there's another team, Malaysian team, climbing this Everest via Tibet. This is how it looks like. It's beautiful. But it's full of rocks, and you could actually get to the base camp with the 4-wheel vehicle, but you've got to acclimatize. You cannot just go straight away to the base camp. You travel, then you have to sleep at the lodging house, and this some people even cycle there. And this is the Tibet Everest base camp. Yeah, so this is, you could look at the tip of the mountain. So over there, this is case 6. That guy that was 4 years older, same guy, he went there for a second attempt to climb the Everest. And he came back from the same altitude, 7,200 meters like before. And he complained this time a distortion of vision. And he said his vision was not normal, but there was zero pain. There was no pain, unlike 4 years ago when he had snowblind. So he said, I can't properly see, but it's not painful. And this is why he saw a distorted vision. Yeah? So on examination, the eyes looks all right. I didn't have a fundoscope with me, but I remember one of the possibilities is having a high altitude retinal hemorrhage. I did have a pocket ultrasound with me, which I checked. There was nothing like retinal detachment or a vitreous hemorrhage. So I thought that he had a high altitude retinal hemorrhage. So he was advised not to climb further because there can be rebleeding. 2 weeks later, he came down, and I took him to see the ophthalmologist. And this was the test done. And from there is more metamorphosia, a distortion of shape and size using this chart. Yeah? Metamorphosia. So this is what he drew on the chart, but the rest of the examination was fine. But on the fundoscope, on the slit lamp examination, on the fundoscopy, he could see that there was some bleeding that could be seen. Yeah. So these are the things. This is some of the tests that was done, for him, it took a year for him to recover. Also, although the literature says it could take like 6 months, but after a year, his vision returned to normal. So up there, when you climb, there are some things that I would just share. There may be mimickers like the haze, which may turn out to be hypoglycemia, or maybe stroke, or asthma, which may turn out to be HIP. In fact, one guy died in the past. What was thought to be HIP was what was thought to be asthma was actually HIP. This guy got acute coronary syndrome. Then I had to treat him at the mountain. This guy, one guy, which was thought to be having haze, but when we sent him to the hospital, the CT scan showed that he actually had a stroke, a hemorrhagic stroke. This is a clinic, Himalayan Rescue Association clinic. If you go there, you will be charged $50 US. So these are some of the hard facts. If you go there, there's not much time left for me, 12:45, but I'll just try to speed up a little bit. This is some of the hard facts. You can't shower, you miss Malaysian food and all. But anyway, I'll just share you some of some researches that was done while I was there. So I thought these are some of the symptoms that you get if you go to the base camp. You got a lot of cough, runny nose, blocked nose, sore throat, nausea, headache, vomiting, dizzy, diarrhea, abdominal pain, chest pain, dyspnea, fever, eye pain, blindness, epistaxis, dysentery, constipation, muscle pain, and even depression. So this is among all the climbers that I asked the symptoms. So basically, this means that these are some of the supportive drugs you need to bring if you go up there. So I did try this system of labeling the drugs, that if they couldn't communicate with me, at least when you look at the label, they could actually self-medicate themselves. And in fact, they saved one climber from Mongolia who was left to die, giving some of these medications, and she actually managed to walk down and then go back to her country. So this is some of the list that I made, in providing the medication. But I did do some study at Kinabalu. This is some of the climbers who volunteered and they stayed 3 days up there. And I compared the blood results when they went and then they came down. I found that there was going to Kinabalu, when they come back, there's slight decrease of hemoglobin, there's slight increase in white cell, and also increase in platelet. Also increase liver enzymes. Decreased magnesium, decreased calcium, increased phosphate. So it means that you're in an inflamed state, and you're also use up the body use up all these minerals. Increased phosphate, likely probably your kidney may be affected, and also even the protein levels will decrease. So all that. And while at the base camp, this is I'll finish my slide soon. I also did research on music, whereby I saw that the oxygen saturation improved from as low as 65% to as high as 88% when you sing. And I presented this paper in Japan, and I actually managed to do a similar study in the chamber, which was published in a journal called the Journal of Voice, which is on Scopus, which is a Q1 journal, which showed that when you sing, the oxygen saturation actually significantly increased. I did a PhD research on effects of music on cardiorespiratory function, perceived exertion, and acute mountain sickness in simulated high altitude environment, looking at music effect versus no music in terms of cardiac, respiratory, rate of perceived exertion, AMS symptoms, and to look at any correlation with them. So this is the summary of my PhD findings. I just one more slide to finish it off. And actually what I found is that what this actually diagram shows from my study is that whether you use arousal or relaxing music as opposed to no music, you have all these effects here. And in terms of AMS symptoms, there was less on the scale of Lake Lewis score when you listen to music. In terms of rate of perceived exertion also, both music, either one, cause you to have a reduced rate of perception. In terms of cardiac, I found that there was a reduction, significant reduction of heart rate, ejection fraction, and even TAPSE. This is representative of the right heart function compared to no music. And this probably shows that it relaxes your heart, because this is still within the normal range, only that relatively lower compared to no music. And in terms of respiratory effect, both music also cause significant increase of oxygen saturation. And with the lung ultrasound, I found that it reduces these B lines. In other words, the leakage or the fluid accumulation in the lung. And you could look at some correlation with arousal music group, that there was a negative correlation with acute mountain sickness when you look at the ejection fraction. With the use of relaxing music, there's a positive correlation with acute mountain sickness when there is an increase of heart rate. And if there's no music use, you find a positive correlation of rate of perceived exertion, as well as there is a negative correlation with the diastolic blood pressure in terms of correlating this parameter with acute mountain sickness. This is just a nutshell. We need another talk for the actual finding. But this is my conclusion slide. Sorry, it took a bit more time. But I suppose that there is a need for physicians accompanying expedition groups to be conversant with high altitude illnesses. And if you could recognize them early, you could prevent death and complications and facilitate this rescue works, because you could even make them walk down by stabilizing them. And we need to anticipate for medical problems. And don't forget, doctors too can be victims of high altitude emergency problems. And you could learn a lot of human and humanity lessons in such an expedition. And I believe there's more researchers, an opportunity of research for everyone to understand mountain medicine better. So in the end, we were all done having climbed to the mountain. We sing Negaraku and we climb back. If you notice, we all look like Sherpas after 2 months at the Everest Base Camp with sunburn and everything. So with that, I would say thank you. Yeah.
Okay, thank you, Dato, for your very interesting sharing. I think most of us will only be able to travel over to Mount Everest just from looking at your pictures. So I don't think many of us will have the chance to go. But anyway, there are a few interesting questions coming up. And I hope that, if they were to follow your advice of singing during the mountain climbing, I hope they are good singers, because otherwise it might cause depression to their other teammates. Anyway, for the first question, what is the accepted oxygen saturation in the higher altitudes?
I think that's a good question. But up there, it doesn't work by the numbers. It works more with the clinical presentation. You got to correlate it clinically. I mean, it's very common. If you go even to Kinabalu, you could get something like around 70% of oxygen saturation, while you're at Laban Rata. Those who are more acclimatized, you could get as high as 85%. So up there at the Everest Base Camp, my oxygen saturation was 65%. It's a scary number to look at if you are seeing any patient at all at your hospital or your clinic. But up there is you are adapting, you are acclimatizing. If you have zero symptoms, then that 65% may be a general acceptable number. In general, nobody has put that number, but it is more of an observational number, whereby at the base camp, something in between 60%, 65% is what is generally acceptable for those who are functioning well.
Okay. So is there any way to acclimatize faster without developing acute mountain sickness?
Naturally, there is no way you could do that. The body takes about 2 to 3 days. But this is my to speed up acclimatization. This is an area of opportunity. I believe that if you improve your lung function by scuba diving, by really expanding your lung function, this might be better. But scientifically, to say certainly that you could actually speed it up, naturally, it's still not there. It's still between 2 to 3 days to get it done. But if you want to artificially acclimatize yourself, then that's where the acetazolamide comes in.
Mm-hmm. So it's only to artificial way.
Yes, that is, yes.
Okay, the third question, what medications and equipments would you recommend a medical team to bring when accompanying the climbers up the Mount Everest? And I also have a personal question, how many Sherpas would that need?
That's an expensive event for you to bring a lot of things. So if you're talking about being ideal, you need to actually create a mini emergency room up there at the Everest, meaning that we do not know who's going to get a heart attack. We don't know who's going to get the use of the AED up there. Who's going to need, because of logistic issues, you have to strap those patients. So you basically need a mini emergency room up there at the Everest Base Camp, and you need to bring all that to set up that clinic. But realistically, that's not possible. Because of the cost, and you will need a lot of Sherpas for you to actually pay and bring all those equipments up. I could function with bare minimum of, it's still like my bag is like a mini clinic. All those supportive medication I've shown in the slides, you need to bring all those drugs. If you have, ideally you need to have an oxygen tank, even a Gamo bag to assist. So all that would be in an ideal state. But if not, at least those medications that I mentioned just now, you need to have the acetazolamide, you need to have the painkiller, the steroids, the samnifadipines, just carry some aspirin, because we don't know who can get a heart attack. These days, some people playing sepak takraw also will come back dropping dead due to cardiac arrest.
Yeah, I think one important message you're trying to say is also don't be too preoccupied with the mountain sickness problem. You don't forget about the common things that you might see at the normal sea level also, right?
That's correct. Yes.
Okay. So the next one, yes. how would you arrange a medical extrication? How is the support system like over there? For example, do the the base camp, are they being organized by the authority or something?
Yeah, there is under the Himalayan Rescue Authority. You cannot just go there. You need to register and pay some huge amount of fees before you're allowed to climb. So that would cover this extrication processes. So when you go there, you have to register, pay the fees, and that would be in general covered if you actually climb up to the top of the Everest. But lower than that, the Everest base camp, you need to buy insurance because if you don't buy insurance, you'll be the charge of taking you down, either paying the Sherpas to do it or the helicopter to bring you down can be like 5,000 US or even more nowadays. So some people, there were people who went, they didn't take insurance and they had to pay by loan.
So all these helicopters and Sherpas would be by the local authority, it's just a private company where you just need to contact
the insurance. You have to be insured, number one. But in terms of extricating from the mountain down, that is under Himalayan Rescue Association. So once you actually registered and paid, you can call them to assist in bringing patients down. Okay,
I see. Okay. So how would you organize exploration team? For example, what will inform your decision on how well prepared you want to be for this team and for the other team? How do you gauge that? How do you do your preparation?
So the question is, how do you organize exploration team?
Yeah.
The doctor in charge. My perspective will be in terms of the medical risks that they can have. If you want to talk about being ideal, everyone before they go should be screened. Everyone should go through, should get a stress test, a minimum, ideally even angiogram done, for the fact that we do not know who may have that risk of getting acute coronary syndrome up there. But for the bare minimum, if you can't organize that, that would mean telling them the risk that there are some things that we would know from the simple blood test, say for the stress test, that they seem to be appearing well and can join in the team. And the rest of it is about organizing these, if there is an emergency situation whereby you need to prepare all the supportive medications, and also you need to know the system over there. If there is a need to bring patient down, make sure everyone is insured, and knowing the most severe emergency situation and handling that emergency situation. I mean, I need to bring some emergency resuscitation situation if, for example, I really need to have them in the worst case scenario intubated and all. So, yeah, that's a scary situation, but as much as possible to support, treat them enough for them to be transported, get on the.
So in a way, you will have a standard set of things that you prepare for every expedition then.
I would prepare it based on my experience, because I can't find a recommendation, because for the fact that you could go as the complete end to end. It's like having a mini ER over there and having all the equipments, and on the back problem of the getting all those equipments up there, and also looking at the likelihood of those things happening.
Okay. So the next question is, how would you manage a 4th degree frostbite at the site?
Okay, that's pretty hard. Okay, tell you what. First of all, make sure you are insured. Over there is still like getting them out from the environment, and this what needs to be done. The initial things like I explained just now from the frost nip could be instituted for them, warm them, but make sure that when you warm them, it's not about a process of warm and then get out cold again and then warm, because that would not be good. Once you get them warm, keep them warm, and then it's about transporting them back to a place which is warm, meaning that flying them off to the place which is warm. Preferably, if you have this patient, actually that you can't, actually you need to elevate these. If it is the legs, you need to elevate them. So these people can use the reason to fly in first class, traveling and get to a center that has a vascular surgery services, and some of them may be found suitable to undergo intra-arterial thrombolysis to open up the vessels again. Also, there's some of the extreme options that could be considered in such case. So it's from the first management, which is where I come in, but to the travel and then to get to a definitive place that for them to be further investigated for definitive treatment if requiring, and that's the only option.
Okay. So I think the last question you have answered previously about whether you recommend pre-participation evaluation. And okay, I think that's about it for the Q&A for your talk, Dato.
Yeah.
So thank you very much for the sharing. I guess, do you want to leave your contact details in case someone wants to get in touch or something?
Yeah, you could, my email is alzamani@yahoo.com, my name, or you could contact me on Facebook. And again, I would like to say thank you for inviting me, and it has been a pleasure to share this talk for the slot given. I hope you benefit from the talk.
Thank you, Dato, for joining us also today. Yeah. So we will next move to the last agenda for the day. Is a closing remark by our organizing chairman, Prof. Sharif. So, Prof. Sharif, could you please? Prof. Sharif, you're muted.
Sorry about that. Thank you very much, Dr. Goh. Assalamualaikum warahmatullahi wabarakatuh and salam sejahtera. I'll be very brief. I would like to thank everybody for joining our sports emergency webinars. As we are moving from a stricter MCO and now are being more relaxed in recent times, more individuals are beginning exercising and participating in sporting activities. We pray and hope that people are cautious in returning to their pre-MCO activities as to avoid injuries and potential emergencies. We are blessed with the presence of all experts throughout the webinar series in sharing their knowledge and experience on sports emergency in their own field. I do hope participants will benefit from this webinar series. And at the same time, I also pray that we do not encounter this emergency. But if we do, hopefully we are prepared to manage with the knowledge that we learn from all speakers. I want to extend my deepest gratitude to all participants for your positive participation during the webinars. I also observed excellent presentation from all speakers and active discussion. So I can conclude that the purpose of the webinars have been accomplished. Thank you also to Dr. Alston Chung and Dr. Sameha, who had worked hard behind the scenes in preparing for this sports emergency webinar series. Also, Prof. Naha, Prof. Halim, Prof. Zulkarnain, Dr. Ramani, and Dr. Goh for their contribution into the webinars. Finally, on behalf of the Sports Medicine Unit, University Malaya, Sport and Exercise Medicine Research and Education Group, and the Malaysian Association of Sport Medicine, as the organizer, co-organizer, I would like to express my appreciation to all participants for taking time out of your weekends to attend this webinar. Thank you once again. Have a pleasant weekend. And to all Muslim, I wish Ramadan Mubarak. Thank you. Back to Alston, I think. Or
Yeah, Dr. Chong.
Okay, yeah.
QR code for the doctors, right?
Yeah. So before we end, I would like to share. Thank you again for all the distinguished guest speaker. Without you, we will not have this wonderful and delightful sport emergency webinar. And of course, we will not forget the active participations from the audience. The answer that the question that they're asking is very is really it's very good, and we can see there is so many audience that actually listen the webinar until the end. Okay, but before we end our webinar, I do really help. I will be very grateful if you can scan the QR code, okay, and give us some feedback. You can also type in this link bit.ly/sport feedback 3, and also give us a constructive feedback so that we can improve our event in the future better. Okay, so okay, here are some of the our upcoming event. Malaysian Association of Sport Medicines organizing our annual general meeting on end of April, which is 24th of April, 3 to 4 p.m. The registration link is bit.ly/MASM EGM 2021, or you can scan the QR code. But this is only for MASM member. Okay, I hope all the member will actually participate and registered and attend the AGM. Okay, and okay, this is one of the our main event, main conference, which is going to held in 11 and 12 September. It's an International Sport Medicine and Exercise Science Conference. It's a virtual conference, okay, that involve a lot of international and local speaker, and there will be a lot of delightful and also very interesting topics that we will discuss. Not only just the football, but also other sport, which is in, and also rehabilitations and injuries and sports science related topic as well. So we will put up this registration in our website, so you can just get the information in the website as soon as possible in Malaysian Association Sport Medicine's website. Okay, and last but not least, okay, this is the QR code for MMA medical practitioners. So please scan the QR code by logging in your MMA event, and also you will able to claim 3 CPD points. For those that having problems with the QR code, kindly email to us at secretary@malaysiansportmed.org, or you can WhatsApp to me at 01237 555 661. I repeat, 01237 555 661. Sorry, yeah, 35661. Okay, so I think that's it for our webinar for today. So thank you everyone, and have a very nice weekend. See you.
Thank you.
Thank you.
Thank you.
Bye.
Bye.
Thank you.